who is with us in all the postgraduate and other training programs. I am really honored and privileged to welcome Dr. Lakshmi Kumar on behalf of ISA Kerala State Chapter to this meeting. Welcome, Madam. We have Dr. Rekha Varghese, who is the Professor, Department of Anesthesiology and Critical Care from the same institute, talking on intraoperative management of the recipient. Welcome, Madam. Dr. Rajesh K, who is the Associate Professor from Amrita Institute of Medical Sciences, is giving the lecture on donor management. I take this opportunity to welcome Dr. Rajesh K. The pre-anesthetic preparation of the recipient. The details of the lecture will be given by Dr. Sindhu Balakrishnan, who is the Associate Professor from Amrita Institute of Medical Sciences. Welcome, Dr. Sindhu Balakrishnan. The post-op aspects of recipient management, the highlights will be given by Dr. Zubair Muhammad, who is the Associate Professor, Department of Anesthesiology, Intensive Care, and Liver Transplant ICU from Amrita Institute of Medical Sciences. On my personal behalf and on behalf of ISA Kerala State Chapter, I welcome Dr. Zubair Muhammad to today's academic meeting. I also take this opportunity to welcome our President-elect ISA National, Dr. Venkatagiri KM, who is with us, guiding us in organizing this program with high academic standard. Welcome, Dr. Giri. I welcome today's webinar coordinator, Dr. Rajesh MC, who is the Scientific Committee Chairman of ISA Kerala State Chapter, and Dr. Vijesh Venugopal, who is the Governing Council member of ISA Kerala State Chapter. We are expecting him soon. And Honorable Secretary of ISA Kerala State Chapter, Dr. Binil Isaac Matthew, to today's meeting. Once again, I take this opportunity to welcome all the senior teachers who are regularly joining us and contributing to actively for all the discussions. And today's colleagues and students, I welcome you to this meeting. Now over to webinar coordinators, Dr. Rajesh and Dr. Vijesh.
Dr. Giri, Dr. Venkatagiri.
Dr. Giri, a few words, please. Dr. Giri.
President Dr. Nazar, Secretary, coordinators, Vijesh and Rajesh, today's faculties, I have a team of transplant anesthesia during this month. Today we have the last in this series with the anesthesia or liver transplant with the 5 speakers. We are keeping the very high standard of IAS academics and attracting more and more PGs. Hope this will continue in the coming year also with the new team coming. And I wish all the best for this team and for the PGs also. All the best once again. Thank you, President.
Academics straight. And we are fortunate to have faculties from one of the leading institutions in India for liver transplant surgeries. They are the pioneers of liver transplant program, not only in Kerala, but also in South India itself. They have, for the last 8 years, I think they have done around 1,000 cases. And we have the experienced faculties, Lakshmi Madam, Dr. Rekha, Dr. Rajesh, Dr. Sindhu Balakrishnan, and Dr. Zubair. Over to you, Madam. Lakshmi Madam.
Yeah, good evening to all of you. I would just at the outset say that I've just come here as a coordinator to probably answer some questions. I've had some personal problems at home. I truly do not know if I'll be able to stay for the full duration, so my apologies for that. I think Dr. Rekha has organized this presentation. I would be happy just to listen on as long as I'm not called downstairs for some things. And if there are questions, I'd be take questions at the end. Thank you. Over to you, Rekha.
Thank you, madam. Dr. Ragha, we'll start with Dr. Rajesh presentation.
Good evening all. Today's topic for discussion is anesthesia for liver transplantation, and I will be discussing the donor management. Since the donor is not a deceased person, any complication or morbidity that occur in the post-operative period may be solely attributed to a surgical or anesthetic mishap. Hence, the process of donor evaluation in liver transplantation is important to ensure donor safety as well as to provide optimal recipient outcome. First, the donor has to undergo a detailed evaluation by medical and surgical team. After obtaining legal and ethical acceptance, the donor will be referred to anesthesiologist for pre-anesthesia evaluation. Anesthetic management of donor focuses on pre-operative evaluation, intraoperative management, and post-operative care. Coming to pre-operative assessment, donor is usually aged between 18 to 55 years, ASA1 or ASA2 person. For example, someone with mild diabetes mellitus or hypertension which is controlled medically. Coming to history, as in every other pre-anesthetic evaluation, we have to take a detailed medical, surgical, and anesthetic history, go through whatever medical or anesthetic records that is available, inquire any history of drug allergy. Similarly, the physical examination should include general and systemic examination, assessment of airway, and examination of spine. Since each potential donor is unique, there is no single test of investigations that can fit for all donors. But the investigations may include a minimum of blood group and cross-matching, CBC, blood sugar, liver function test, baseline coagulation parameters, urine analysis, renal function test, serum electrolytes. A chest X-ray and ECG are also performed routinely. Further investigations may be ordered as clinically needed or as an institutional protocol. We routinely perform pulmonary function test, TMT, and echocardiogram for all donors. Keep a low threshold for investigations and diagnostic tests. After pre-anesthesia evaluation and optimization, obtain an informed consent. Explain the anesthetic procedure in brief. It may be appropriate to explain the need for post-operative ventilation in rare occasions. Make sure that the arrangement for blood and blood products has been done. Prescribe anti-aspiration and anti-anxiety medications. Give pre-operative fasting instructions and psychologically support the donor and family. Coming to intraoperative management, as in any other major abdominal surgery, the plan of anesthesia will be general anesthesia with endotracheal intubation and controlled ventilation, which may be supplemented with the thoracic epidural or erector spinae block. Intraoperative monitoring include ECG, SpO2, arterial blood pressure, CVP, EtCO2, temperature, and urine output. Precautions has to be taken to prevent intraoperative hypothermia and deep vein thrombosis. Measures to prevent DVT include initiation of low molecular weight heparin prophylaxis, application of TED stockings or pneumatic compression stockings in selected cases. Preparations to manage a massive hemorrhage. In the rare event Injury to blood vessels or accidental slippage of vascular clamps can lead to sudden massive bleeding. So secure 2 large bore IV access, preferably 16 gauge cannula, apart from a 7 French central venous line. Make sure the availability of infusion pumps for administration of vasopressors and inotropes as needed. Blood products and plasma volume expanders like 20% albumin should be available immediately if the situation demands it. Strategies to reduce intraoperative blood loss. Commonly used anesthetic methods to reduce blood loss during liver resection include a low central venous pressure technique or a high stroke volume variation method. CVP guided fluid management during hepatectomy. CVP reflects hepatic sinusoidal pressure, hence lowering CVP during parenchymal resection reduces hepatic sinusoidal congestion and subsequent bleeding. The target CVP during hepatectomy, which has been shown to reduce intraoperative blood loss and the need for blood transfusion, is about 5 millimeters of mercury or less. A low CVP can be produced and maintained by fluid restriction to 2 to 4 ml per kg per hour or even less. Achieving a low CVP can be further aided by reverse Trendelenburg position as well as by addition of pharmacological agents like nitroglycerin and furosemide. Potentially fatal consequences of a low CVP technique during liver resection include significant hypotension, compromising organ perfusion, and air embolism. Stroke volume variation guided fluid management during donor hepatectomy. Stroke volume variation is one of the dynamic parameters of hemodynamic monitoring used to assess volume status and fluid responsiveness in mechanically ventilated patients. It has been shown that CVP values significantly correlate with stroke volume variation, thus implying that a CV can be used as an alternative to CVP monitoring during liver resection in patients with diseased liver. A stroke volume variation of 10 to 16% has been shown to reduce blood loss during liver resection. Usefulness of SVV values was also reported in patients undergoing laparoscopic liver resection. We can go through this algorithm. Post-operative care. On-table extubation is possible in most cases unless complicated by major intraoperative bleeding or hypothermia. Early ambulation will prevent development of deep vein thrombosis and pulmonary embolism. Coming to post-operative pain management, thoracic epidural analgesia provides the best post-operative pain relief following hepatectomy. Either local anesthetic agents alone or in combination with opioids can be administered epidurally to provide optimal analgesia. A combination of neuraxial preservative-free morphine and intravenous opioid-based PCA can provide better hemodynamic stability and allows less fluid administration in the post-operative period. What currently favors is a multimodal analgesia combining regional blocks like wound catheter analgesia or erector spinal blockade with intravenous opioids and additional boluses of another intravenous analgesic agent like paracetamol or NSAID. Post-hepatectomy complications. Patients should be observed for complications like bleeding, transfusion-related lung injury, coagulation abnormalities, DVT, and pulmonary embolism. Following liver resection, coagulation abnormalities peak on 2nd to 3rd post-operative day. Lab investigations of coagulation reveals a prolongation in prothrombin time and INR and a decline in platelet count. But there is a growing body of evidence that post-hepatectomy patients are hypercoagulable, as evidenced by dynamic tests of coagulation such as thromboelastography. Also watch the patient for complications like bile leak and infections. Infections can be intra-abdominal or catheter related. Also keep a close watch on derangements in liver function. With the extreme dysfunction, it may end up in post-hepatectomy liver failure. Thank you for your patient listening.
Dr. Rekha, the questions come at the end. Is that the plan? Dr. Rajesh?
Yeah, there is only one question. Either Dr. Rajesh is available, he can take it now, or we can have it at the end of the procedure. There is actually one question. Is invasive arterial BP monitoring needed for donor? And Madam has answered it also.
So I think Dr. Valli, she's my classmate from thing. She says, how are you monitoring SVV introp? So Valli, we as a routine don't do SVV for donors because currently our donors are robotic. And you know that when there's increase in intra-abdominal pressure, SVV ceases to be of any value. We do it for the recipient, both the pulse pressure and stroke volume. And we at least get a trend, even though the values are the times when the stroke volume variation gets unreliable in the recipient is when the surgeon is manipulating the IVC. So I just know without looking up that he's touching the IVC because the SVV, which was showing 10 or 8 or 12, gets bizarre. For a donor, currently at Amrita, SVV is not being monitored because most of our donors are robotic. Even if they are open, we don't monitor SVV because we try to do a restrictive strategy. Dr. Rajesh has very nicely mentioned that an SVV of, I think he said 12 or 14, which clearly says a lowered volume strategy during donor hepatectomy is what he intends. I hope that answers the question. And it's actually good to see you and hear your questions well. I think we can move on. I'm sorry if I took more time, Rajesh. Please go on by your schedule.
No, madam. Madam, with robotic, it will take more than usual time, no?
A robotic at our institute now takes somewhere between 8 to 10 hours. In the last couple of months, they have introduced intermittent Pringle maneuver, which shortens the duration of surgery, and it really hasn't reflected on graft quality or enzymes post-operative. So yeah,
I didn't get to.
Commonly asks safety of epidural in donors. I think Rajesh himself is the one who has done his research where he's looked at dynamic coagulation parameters like a TEG in a donor versus a PT-INR or an APTT, and has shown that there is a hyperfibrinogenemia, or that the dynamic clotting, the thromboelastogram is very, very normal even when the INR in the donor is 1.9, which is why world over centers doing open donor hepatectomy are still comfortable putting that epidural needle and catheter for the donor.
So what are the intraop investigations for the donor?
For the donor intraop, we usually don't do too much. Sometimes when you find a potassium on an ABG which may appear high, you may want to counter check that with the lab. If you see a blood loss, we usually go by the ABG hemoglobin because it's instantly available. But some of us may want to send to the lab. We, as a routine, do not check coagulation for the donor unless there is some bleeding issue which the surgeon reports. Somebody has asked about fluid for the donor. Fluid for the donor, at our center, Plasma-Lite is a fluid of choice. If it were an open donor, restrictive strategy, about 4 ml per kg per hour until the liver resection. And once the liver graft is resected, you can fill. For a robotic or a laparoscopic surgery, you allow the patient to take a clear fluid like carbolode pre-operatively until 2 hours before the surgery. Then you give 2 ml per kg per hour. The flag, the checklists are, is the BP okay? Is the urine output okay? Are the lactates normal? If you find no to any of these questions, the first response is 250 ml fluid bolus. And beyond that, we don't keep giving fluid boluses in the robotic surgery. We start off with a dose of vasopressor. So as much as possible restrictive, and any increase in fluid is after the graft is resected. The CVP is unreliable when you do robotic surgery. Sometimes you will find a CVP is 7, sometimes it is 14. So the only indication of fluid filling in the donor in a minimally invasive surgery is the surgeon's verdict. We keep asking them, is the IVC empty or is it full? And then give based upon that. Any other thing is quite unreliable in laparoscopic surgery or robotic surgery. Dr. Rajesh, I think you take it up because I will go on talking. There's a problem with me.
Okay, madam, then we can go to the next session. It's Dr. Sindhu is pre-anesthetic evaluation and preparation of recipient. Dr. Sindhu?
Yes. Am I audible?
Yeah, you're audible and clear.
I'm going to share my screen. Is it clearly visible?
Yes, yes.
So, good evening, dear friends, teachers, students, and all my colleagues. At the outset, I'd like to thank ISA Kerala chapter for giving me this wonderful opportunity to be a part of this postgraduate teaching, which is really intense. So today I'm here to discuss about pre-operative evaluation and preparation of a liver transplant recipient. Liver transplant, as you all know, is the definitive treatment for end-stage liver disease and also for acute fulminant liver failure. Since the first transplantation in 1963 by Dr. Karl Storz, there has been tremendous improvement in this specialty of liver transplant surgery. There has been refinement of the surgical techniques, improvement in the quality of anesthesia and donor care, along with better preservation of organs and also availability of better immunosuppressive drugs with fewer side effects. So this has resulted in a 1-year survival of close to 90%. Now, encouraged by this success story, more and more centers are coming up with liver transplant surgery. And I'm sure more than few of you are going to encounter patients who are going to be affected with end-stage liver disease coming for transplantation or transplant-related procedures. So, I'm not able to move my slide. Okay. Let us quickly look at the indications for liver transplantation. Liver transplantation, as I said earlier, is indicated for acute fulminant liver failure or viral etiologies due to drugs and toxins because of autoimmune hepatitis, vascular disorders, fatty infiltration of liver as in pregnancy and Ray's syndrome, and also in some inherited conditions which rarely present as acute liver failure like Wilson's disease. It is indicated in chronic liver diseases due to viral etiologies like due to hepatitis B and hepatitis C, alcoholic liver disease, hepatocellular carcinoma, autoimmune hepatitis, numerous inherited disorders like hemochromatosis, Wilson's disease, and alpha-1 antitrypsin deficiency. Also, it is indicated in patients with primary biliary cirrhosis and primary sclerosing cholangitis, vascular disorders like Budd-Chiari syndrome, and metabolic and miscellaneous causes are other indications like for NASH, cryptogenic cirrhosis, amyloidosis, sarcoidosis, urea cycle deficiencies, defects, and polycystic liver disease are some of the indications for liver transplant. Now, how do you decide whether the patient should undergo a liver transplant or not? So for deciding who should undergo a liver transplant, we need to have certain scoring systems to identify who are the sicker ones and who are the ones who will benefit from transplant. Until 2002, the Ctp score or the child to Ctp Score, as you all know, was used to find out patients, it was used to assess the severity of liver disease. Now, the Ctp score has 5 parameters. I'm sure you all know about these: ascites, bilirubin, albumin, prothrombin time, and encephalopathy. And each of these is marked points from 1 to 3. And based upon the total score, we can divide the patients into child A, child B, child C. Child C being the sickest with a 1-year survival of only 45%. Now, the wait list was decided based upon this child scoring. But the problem with this child score was that there were 2 variables, that is ascites and encephalopathy, which were subjective variables. So this resulted in patients getting higher up in transplant list, patients who were less sick got higher in the transplant list. And so we needed a more objective scoring. So then we introduced the Mel score, which is the model of end-stage liver disease score. The Mel score was initially used for patients to predict the 3-month mortality of patients undergoing transjugular intrahepatic portosystemic shunting procedure. But it has been found to reasonably predict the mortality of a patient with end-stage liver disease. Now, the Mel score is in the Mel score calculation, it is actually the logarithmic transformation of the serum bilirubin, the INR, and the serum creatinine. And based on this, you can get a score from between 6 to 40. The higher the score, the sicker the patient. Now, what is a cutoff value of Mel at which you will transplant a patient? Patients with a Mel score of more than 15 are only to be transplanted. Patients with lesser scores, if they are transplanted, the mortality from transplant is higher than that due to disease. So you need to have a Mel score of at least 15 to consider or take up a patient for transplant. Now, the predictive accuracy of the Mel score has been improved by adding certain other variables to the Mel score. So you have Mel sodium, which has a better predictive mortality, which predicts mortality better than Mel score. You have an integrated Mel score where age and albumin are included in the Mel score, and that has a better predictive accuracy of mortality than the Mel score. In pediatric patients, you have the PEL score. Now, there are certain situations like a hepatocellular carcinoma, cholangiocarcinoma, where the patients have a low Mel score, but the risk of mortality in these patients will be higher than that of a patient without hepatocellular carcinoma. So these patients need to be given extra points so that they can move up higher in the transplant, so that they don't die waiting for transplantation. So MELD exception points are given in other situations as well, like in acute liver failure, patients with a primary graft dysfunction following within 1 week of transplantation, patients with HCC, patients with cholangiocarcinoma, patients with Hepatopulmonary Syndrome, Proto-Pulmonary Hypertension, refractory ascites, and hepatic encephalopathy, besides numerous other metabolic and vascular disorders. Now, today I will be going through the evaluation of a cirrhotic patient coming for transplantation. I will be dealing only with patients with cirrhosis and not any other indication for transplantation. I'm sure all of you would have seen patients, cirrhotic patients who are debilitated with multi-organ dysfunction. So what I propose to do today is to go through the organ systems one by one and see the effects of cirrhosis on these organs and its implications for us. Cirrhosis, as you all know, is a serious and progressive pathological disease of the liver. It is characterized by hepatic necrosis, followed by fibrosis and nodular regeneration, leading to distortion of the normal cellular architecture and the vascular architecture. This distortion of the vascular architecture results in portal hypertension with its associated splanchnic vasodilatation and a high cardiac output state in these patients. There is also impairment of the synthetic and metabolic functions of the liver. Now, this is an interesting table which I found in Stolting's textbook of anesthesia. you can see the heading of this table, which shows the systemic effects of cirrhosis. And you can see almost all the organ systems are affected in cirrhosis. So a pre-anesthetic evaluation of this patient should look into the history of CLD, including the etiology, the symptomatology of the patient, what are the symptoms and how it was diagnosed, the history of admissions to hospital, whether the patient was admitted in the ward, whether he had any ICU admissions, was he ventilated, did he develop renal failure, did he develop encephalopathy. So we need to also look at all the other decompensations in terms of GI bleed, whether the patient has developed a jaundice, whether the patient has developed an encephalopathy, did he develop renal failure during these admissions. Also, we need to assess the baseline quality of life of the patient. Also look at all the comorbid illness that the patient has. Are the comorbid illnesses well controlled, or is there any life-threatening comorbid illness that the patient has? Also, we need to look at what are the medications the patient is taking, both related to the liver as well as related to the comorbid illness. We need to look at addictions. Patients who are addicted to alcohol need to have at least a period of 6 months of alcohol abstinence before we consider for transplantation. Infections, a history of all bacterial, viral, fungal infections. And in recent times, we need to look at whether the patient has had a COVID infection and the severity of the COVID infection as well. So while we are assessing patients, we need to look for features of portal hypertension in our patient. Has the patient had a gastroesophageal varix, which has been ligated endoscopically, or has he undergone a sclerotherapy? Did he have any gastric varix? Was a glue injection done? And most of these patients with gastroesophageal varices may be on prophylaxis with beta blockers to prevent a rebleed. Ascites is another feature of portal hypertension along with hypoalbuminemia, and these patients will be usually on diuretics and they may be undergoing paracentesis recurrently, weekly, or even every third day. So if they have undergone paracentesis, we need to rule out a spontaneous bacterial peritonitis in them. Now coming to the respiratory assessment, we need to look for the effects of cirrhosis on the lung. They are related to the vascular complications of cirrhosis on lung, mainly Hepatopulmonary Syndrome and Proto-Pulmonary Hypertension. Also, you may get hepatic hydrothorax. So these are the three main lung manifestations of cirrhosis in the lung. Besides, you need to look out and rule out patients' infections in the lung, and also other comorbid lung conditions like whether the patient has a COPD, bronchial asthma, OSA, or pulmonary embolism. Now, hepatopulmonary syndrome is diagnosed when you have arterial hypoxemia in the background of CLD. The triad of hepatopulmonary syndrome is chronic liver disease, arterial hypoxemia with a high AA gradient, that is more than 15 millimeters of mercury, and also evidence of intrapulmonary vasodilatations must be present. Now, hepatopulmonary syndrome has been graded as mild, moderate, severe, and very severe based upon the PaO2 levels, that is the arterial PaO2 levels. Patients with a PaO2 of less than 50 millimeters of mercury are said to have very severe hepatopulmonary syndrome. Capillaries increases oxygen defect from the alveolus. To reach the RBCs, the oxygen has to travel a lot of distance. Besides, there is a hyperdynamic circulation in cirrhotic patients, and this results in a rapid transit of blood through the intrapulmonary capillaries. Plus, there will be opening up of arteriovenous bypass channels in the lungs. So there are three abnormalities in hepatopulmonary syndrome. That is, these patients have a diffusion defect, they have a ventilation perfusion mismatch, and they also have a shunt. And these are the three mechanisms by which they develop hypoxemia. Now, the signs and symptoms of hepatopulmonary syndrome. It is very difficult to differentiate the signs and symptoms of hepatopulmonary syndrome because there is a clear overlap of symptoms in cirrhosis and hepatopulmonary syndrome. Patients have dyspnea, they have platypnea, they have orthodeoxia, digital clubbing, and cyanosis. Now, below is the picture of an echo, which shows the appearance of microbubbles in the left side, and I'm coming to that in my next slide. Now, how do you diagnose hepatopulmonary syndrome? Patients are made to sit up and their oxygen saturation is to be monitored with a saturation probe. Any saturation less than 96% warrants an investigation for hepatopulmonary syndrome. We need to do an arterial blood gas in the sitting position, and you need to look for hypoxemia in the ABG, that is a PaO2 of less than 80 millimeters of mercury with an AA gradient of more than 15 millimeters of mercury. If there is a shunt, then if there is a high AA gradient, you need to do a contrast enhanced echo in these patients. Contrast enhanced echo is the most sensitive test for diagnosing hepatopulmonary syndrome. In this, agitated saline is injected through a peripheral vein, and in the 4-chamber view that I earlier showed in this figure, in the 4-chamber view, we need to look for appearance of microbubbles on the left side of the heart. Appearance of microbubbles within 1 to 2 cardiac cycles indicates that there is a true cardiac shunt, that is a PFO or an ASD or a VSD. But appearance after within 3 to 6 cycles suggests the presence of a hepatopulmonary syndrome. Now, this is the most sensitive test for diagnosis of a hepatopulmonary syndrome, and it is difficult to quantify the degree of hepatopulmonary syndrome in the patient. So we need if you want to quantify, then you need to do the technetium label macroaggregated albumin. We do not do this in our center. A presence of more than 6% of macroaggregated albumin in the brain is highly suggestive of hepatopulmonary syndrome. And patients, now, the definitive treatment of hepatopulmonary syndrome is liver transplantation, and patients do improve following liver transplant within 6 months to 1 year. Patients with a PaO2 of less than 50 millimeters of mercury and patients with more than 20% of macroaggregated albumin in the brain, they do poorly after transplantation. Now, coming to the next pulmonary complication of cirrhosis, which is portopulmonary hypertension. That is, pulmonary hypertension in the setting of portal hypertension is called as portopulmonary hypertension. But we need to define the pulmonary hypertension based on findings from the right heart catheterization, according to the World Symposium of Pulmonary Hypertension, which was conducted in 2019. To diagnose pulmonary arterial hypertension, you need a mean pulmonary arterial pressure of more than 20 millimeters of mercury, along with a pulmonary vascular resistance of more than 240 dynes second centimeter to the power of -5, and a pulmonary capillary wedge pressure should be less than 15 millimeters of mercury. Now, let us look at the pathophysiology of portopulmonary hypertension. In patients with cirrhosis, there are numerous portosystemic shunts at the gastroesophageal junction, the splenogastric shunt, splenorenal. So there are multiple channels, and these result in vascular mediators so what happens is these waste or the toxic substances really from these areas migrate through these shunts into the systemic circulation, and they reach the pulmonary vasculature, leading to intimal proliferation, medial hypertrophy, and fibrosis, leading to an increase in pulmonary vascular resistance. Also, the high cardiac output state in cirrhosis results in increased shear stress on the vascular wall, leading to vascular hypertrophy. Along with this, there may be some role of inherited factors in the development of portopulmonary hypertension. Now, the signs and symptoms, based on this, it is difficult to identify that the patient has portopulmonary hypertension. Dyspnea on exertion, fatigue, syncope, palpitations, chest pain, orthopnea are some of the symptoms of portopulmonary hypertension. We need to identify portopulmonary hypertension. ECG will see a right atrial enlargement or a right ventricular hypertrophy. In echo, you can see in echo, if you see a right ventricular systolic pressure of more than 45 millimeters of mercury, you need to proceed with the right heart catheterization, which will help you to differentiate the pulmonary hypertension measured because of really actual pulmonary hypertension, or a hypervolemic state, or a hyperdynamic because of the high cardiac output state seen in portal cirrhotic patients. Now, the treatment of pulmonary hypertension, these patients can be treated with prostacyclin analogs like epoprostenol or endothelin receptor antagonists like bosentan, ambrisentan, or a phosphodiesterase 5 inhibitor, that is sildenafil. So once the patient undergoes treatment, after a 3-month period, we need to reassess the pulmonary arterial pressure with the right heart catheterization study before we can take up the patient for transplantation. Now, all patients with the mean pulmonary artery pressure less than 35 millimeters of mercury can undergo transplantation safely. But liver transplantation is contraindicated in patients with PA pressures more than 50 millimeters of mercury. Now, coming to the third complication, pulmonary complication of cirrhosis, which is hepatic hydrothorax, is basically transmigration of fluid through the openings of the diaphragm from the intra-abdominal cavity. The sum of the positive intra-abdominal pressure and the negative intrathoracic pressure will determine the flow of fluid into the chest. Usually this is right-sided in 77% of the patient, but it can be left-sided in 13 to 17% of patients and bilateral in 2 to 10%. You need to rule out cardiovascular and pleural causes of pleural effusion. Now, the symptoms and signs are usually cough with breathlessness and hypoxemia, and some patients may go into a respiratory failure. Now, this is an X-ray of a patient who came with severe breathlessness and respiratory failure in our ICU, who got intubated, and he had a hepatic hydrothorax, which we had to drain, and we had drained about 3 liters of fluid in this patient. The management of hepatic hydrothorax, you should see your patients in the preoperative period, and these patients will be usually on a salt-restricted diet. You should decide whether you need to do a thoracocentesis before surgery, and if your thoracocentesis is done, you need to do a cell count of the pleural fluid to check if there is infection and treat the patients with appropriate antibiotics. Sometimes these patients may have undergone TIPS or a pleurodesis in case the patient develops recurrent hepatic hydrothorax. So with that, we come to the end of the pulmonary assessment of patients with cirrhosis. Now going on to the cardiovascular assessment. Now the heart is put under tremendous stress during the surgery, and during the next talk, Madam is going to tell you about all the points at which the preload reduces, where the afterload is going to increase, and where the myocardial contractility is at the least. Actually, the stress on the heart is like as though the patient is running a marathon. That much stress is coming to the cardiovascular, to the heart during a transplant surgery. So we need to assess. It was actually thought that, and this stress of the surgery will be poorly tolerated by patients with cirrhotic cardiomyopathy, patients with coronary artery disease, heart failure, arrhythmias, and valvular heart disease. So we need to identify the presence of these in the preoperative period and optimize the patient appropriately. Now, our patients should be assessed for heart failure, and we precisely all the risk factors for developing left ventricular systolic dysfunction and diastolic dysfunction in the general population will be applicable to our cirrhotic patients, like diabetes, uncontrolled hypertension, will all lead to systolic and diastolic heart failure. But we are going to specifically look for cirrhotic cardiomyopathy. In these patients, they have a normal resting echo with a high cardiac output. These patients have a diminished contractile response to stress and incomplete diastolic relaxation and reduced chronotropic effect during the stress test. In the ECG, they will have a prolonged QT interval. Now, all these patients with a heart failure, we should try to optimize the heart failure with drugs like beta blockers, spironolactone, beta blockers, diuretics, and AC inhibitors as permissible by the blood pressure of the patient and the renal functions. But what value of EF is a contraindication for transplant? That is, an EF of less than 40% is usually, these patients usually do not tolerate the transplant well. Now, earlier it was thought that coronary artery disease does not occur in CLD patients, but that is not true, because all the risk factors, as in general population, are applicable in patients with cirrhosis as well. Age more than 50 years, diabetes mellitus, patients with NASH, hypertension, hyperlipidemia, patients with a history of cigarette smoking, and a family history of coronary artery disease should be evaluated for CAD before transplant. Patients may have arrhythmias like AF, SVT, QT prolongations, and all these should be treated before surgery, and arrhythmias may be aggravated by the sympathetic stimulation of surgery, and acid-base abnormalities and electrolyte abnormalities will worsen the arrhythmias in these patients. So these patients should be treated pre-op itself. In the cardiac evaluation, a history and physical examination is required. ECG should be looked at for the STT changes, Q waves, RBBB, LBBB, right atrial enlargement, right ventricular hypertrophy, whether there are arrhythmias and QT prolongation. An echocardiography is required to look at the left ventricular ejection fraction, to look for regional wall motion abnormalities and valvular abnormalities. It is difficult to do a stress testing in patients with cirrhosis, as most of them have ascites, generalized edema, and they are usually fatigued and they cannot run a treadmill. So what is usually done is a pharmacological stress testing. In our institute, we practice doing the dobutamine stress echocardiography, which has a high negative predictive value for obstructive coronary artery disease and post-operative cardiac events. We can also consider doing a vasodilator myocardial perfusion scintigraphy. Now, who are the patients you will require a coronary angiogram before liver transplant? Patients who have undergone percutaneous coronary interventions within 2 years, patients with symptoms highly suggestive of ischemia with age more than 60 years, patients with a long-standing diabetes with end organ involvement, patients with an abnormal stress test, and patients with regional wall motion abnormalities on echo screening should undergo echocardiography, should undergo coronary angiography before surgery. Now, what are the absolute contraindications? Which are the patients you cannot take up for transplantation? Patients having a lesion which is not amenable to angioplasty, and patients who cannot undergo angioplasty because she cannot tolerate the anticoagulants or the antiplatelet medications following angioplasty. Patients who require a CABG but cannot undergo CABG because they are in child B or child C status, which carries a high mortality in these patients. Now, coming to hepatorenal syndrome, this is a serious complication which has a high mortality and morbidity, and it affects mainly the kidney. It causes functional circulatory changes in the kidney overpower the normal compensatory mechanism, resulting in a reduced glomerular filtration rate. Now, let us look at the pathophysiology of HRS. Portal hypertension is characterized by increased portal pressures with splanchnic vasodilatation. This results in nitric oxide and prostaglandins and endocannabinoids causes release. These comes into the systemic circulation, which cause peripheral vasodilatation, and there is a decrease in effective arterial blood volume. And this decreased effective arterial blood volume results in increased renin-angiotensin-aldosterone secretion, increased sympathetic nervous system activation, and increased ADH secretion, which causes sodium retention, renal vasoconstriction, and reduced renal blood flow, which is responsible for the hepatorenal syndrome. We should differentiate hepatorenal syndrome from pre-renal azotemia because of massive paracentesis and aggressive diuretic use in patients with ascites, along with, or it could be, the other possibility is that the patient could have developed acute tubular necrosis, or the patient may be having an underlying chronic kidney disease. Now, this is the latest classification of HRS. HRS earlier was classified as hepatorenal syndrome 1 and hepatorenal syndrome 2, but now the classification is hepatorenal syndrome HRS AKI and HRS non-AKI. So I'm not going into the classification of HRS. Now, how do you diagnose that the patient has the HRS? Patients will not respond the urine output does not improve with diuretic withdrawal or a 2-day challenge with albumin in the absence of shock or nephrotoxic drug use, and the patient should not have any structural kidney disease. Now, how is HRS treated? All these patients will be treated with vasoconstrictors along with albumin. The vasoconstrictor of choice is terlipressin, and some of our patients do come in for transplantation on terlipressin 2 mg per every 6th hourly or every 8 hours. So terlipressin is the vasoconstrictor of choice in patients with HRS. It acts on vasopressin 1A receptor and causes parenchymic vasoconstriction. The other vasoconstrictor which we can consider in treating HRS is norepinephrine, or a combination of midodrine with octreotide is used in some of the other countries around the world. So the next complication and the next system which we need to look at is the central nervous system. We often see that patients with cirrhosis are drowsy, unresponsive, and so we need to think about hepatic encephalopathy in these patients. This is basically a disturbance of the CNS function because of hepatic insufficiency, and it is characterized by neuropsychiatric manifestation. Below is the West Haven classification of hepatic encephalopathy, which I'm sure all of you are familiar with. Now, what is the pathophysiology of encephalopathy? In the diet, once the proteins are metabolized, you have ammonia, which is released into the systemic circulation, which is released, and it enters through the portal system into the liver, where ammonia gets converted to urea, and this urea is excreted via the kidney. Now, in patients with cirrhosis, there are portosystemic shunts which take the ammonia into the brain, where ammonia gets converted, which ammonia combines with glutamate to form glutamine, and this glutamine is responsible for cerebral edema, intracranial hypertension, and neuronal dysfunction. So we need to look for precipitating causes. The precipitating causes for hepatic encephalopathy are GI bleeds, constipation, infections, patients who have developed a HCC recently, patients who have been given sedatives. So these are some of the precipitating factors, and we need to treat the precipitating cause. If the patient has developed a GI bleed, he has to undergo endoscopy and endoscopic varicose ligation. If there is constipation, we need to treat the constipation. So basically, the management of hepatic encephalopathy is treatment of the precipitating cause. Also, if the patient does not improve, we need to think of other differential diagnoses like an intracerebral bleed, or if the patient has seizures, or is the patient just having hypoglycemia. We need to administer non-absorbable disaccharide, mainly lactulose, and ensure that the patient passes stools at least 3 times. Non-absorbable oral antibiotics like rifaximin are given to treat hepatic encephalopathy. You also have L-ornithine L-aspartate, which helps in taking up the ammonia in the liver and metabolizing ammonia to urea, and also to reduce the glutamine formation in the brain. In the endocrine system, you can have impaired glycogenolysis and gluconeogenesis, and there is a reduced metabolism of insulin in these patients, which predisposes them from hypoglycemia. So it is important that patients with cirrhosis, when they come for surgery, we need to keep monitoring their blood glucose to ensure that they do not go into hypoglycemia. Some of these patients may be having Hepatorenals Syndrome, which occurs in 24 to 47%, which is characterized by a low mean arterial pressure with high serum concentrations of renin and noradrenaline. This is thought to be because of exhaustion of substrates for the synthesis of cortisol, and there is also a disruption of the hypothalamo-pituitary axis. These patients with Hepatorenals Syndrome are at a risk for HRS-AKI, sepsis, and short-term mortality. And these patients will be usually taking hydrocortisone in the perioperative period. So we shouldn't forget to treat and continue the hydrocortisone in these patients as they come in when they come in for surgery. Metabolic abnormalities are common in patients with cirrhosis. acid-base abnormalities and electrolyte abnormalities are seen. The most common acid-base and respiratory is respiratory alkalosis with metabolic acidosis. You can get respiratory acidosis in patients with hepatic encephalopathy. Electrolyte abnormalities can be seen of sodium, potassium, both hyper and hypokalemia. Hyper and hyponatremia are common in this group of patients and may require corrections and requires careful monitoring in the perioperative period. Hypomagnesemia is a common occurrence in patients with cirrhosis and requires correction. Now, liver function tests may be abnormal in these patients. These patients will have jaundice. The liver enzymes may or may not be elevated, depending, and it depends upon the etiology. Patients will have low albumin. There is going to be an albumin globulin reversal, and also coagulopathy is seen in these patients. The coagulopathy part I'm going to come in the next slide. So a hematopoietic assessment of these patients is very essential because the main problem during the surgery is going to be bleeding, which Madam is going to describe in the subsequent slides in the next talk. So hematopoietic assessment, the liver has an important synthetic function of both protein and lipid. And because of this, there's going to be derangement of both cellular and soluble components of the blood. The liver synthesizes procoagulant factors, that is factor 2, 5, 7, 9, 10, 11, and fibrinogen. Also, the liver is a place where we get synthesis of anticoagulant factors, namely protein C, protein S, and antithrombin 3. It is also an important place where the thrombopoietin synthesis happens, which is responsible for maintaining the platelet count in the patient. So this is basically to explain and show that in cirrhosis, there is a systemic inflammatory response, which leads to neutrophil activation, and with this neutrophil activation results in release of interleukin-1, interleukin-6, and tumor necrosis factor alpha, which results in decreased production of 2, 5, 7, 9, 10, 11 coagulation clotting factors. Also, a fibrinogen defect develops. Patients have a low antiplasmin level and tissue plasminogen activator and high PAI, that is plasminogen activator inhibitor. Now, this SIRS also results in an endothelial dysfunction, which releases the endogenous heparinoids, which causes an elevation in tissue factor, factor 8 and von Willebrand factor, and also decreased anticoagulant factors like protein C, S, and antithrombin 3, and decreased plasminogen. Now, whether the patient will bleed or whether the patient will clot will depend upon which pathway gets activated in cirrhosis. So in a laboratory examination in these patients will usually relieve anemia, and we need to keep a hemoglobin of at least 8 gram per deciliter before we take up for the surgery. Patients will have thrombocytopenia, a platelet count of usually at least above 50,000 is required before transplantation. Although we take at a lower level during surgeries, we may transfuse at the time of induction in these patients. Patients have a leukopenia. This is mainly because of splenic sequestration, and these patients have deranged PT-INR, APTT, and fibrinogen levels, which may require transfusions. PT-INR above 2.5 is we usually transfuse FFPs, and fibrinogen levels less than 150 milligram per deciliter warrants a transfusion. In some of these patients, we may do a TEG to assess the coagulation before surgeries. Most of these patients have malnutrition. Patients who are cachectic may require nutritional supplementation before they're taken up for surgery. And obesity with a BMI of more than 40 is a relative contraindication for surgery. All the transplant recipients should be screened for infections. History of immunizations should be looked at. Previous episodes of SBP, previous episodes of admission with bacterial, viral, and fungal infections. Screening tests for HIV, hepatitis A, dengue, HCV are all done a battery of tests are done so that we identify patients who are having viral infections before surgery and start the appropriate antiviral medications. In the current times, we do a COVID screening, RT-PCR, for all patients, including the donor. The donor should also be screened for infections before they come in as donors so that the infection is not transmitted through the transplanted organ. A psychiatric assessment of the patient is not done to determine if the patient can successfully navigate the complexities of transplantation, and so that they can make recommendation to mitigate these risks. Alcohol dependence and substance abuse is analyzed, and patient's mental status also assessed. A screening for malignancy in the ear, nose, throat area, because most of these cirrhotic patients are also smokers. So they may have malignancies in these ear, nose, throat areas. And patients are screened for GI malignancy with markers like CEA, CA19, 9, and also alpha-fetoprotein. Urological malignancy is screened by giving a PSA test, and gynecological screening with the mammogram and pap smear are done in these liver recipients. So I'm sure that all of you will agree with me that the tightrope walk begins in the preoperative evaluation of a cirrhotic patient and continues into the intraoperative period and the postoperative period. With that, I conclude my talk today. Thank you.
Thank you, Dr. Sidhu. Can we go to the questions in the chat box? I think a couple of questions are related to the previous talk by Dr. Rajesh. What vasopressin is started for the donor, and regarding the lactate monitoring, both as a reference for volume status and liver dysfunction.
Sorry, I got the lactate. Lactates, although we believe specific for the liver, can be a variant. So it's not just a fluid, it's not how much liver is left. It could be by a variety of factors. If you have a diabetic patient, it may be a little high. So I am not able to particularly say that lactates, of course, a rising lactate in a donor is not good. But what actually causes an elevation of lactate, I'm still unclear. It's not related to the duration of resection or ischemia or the use of Pringle or the fluid or the mean arterial pressure. But some of these grafts, perhaps it's related to the graft function. You can have a lactate which is, say, something which rises from 1.5 to about 6 towards the end of surgery. This is by our labs. Individual labs could vary. Most often they return to normal at 12 hours after the inciting event, which is resection. So if the resection has happened at about, say, 4 o'clock or 3 o'clock in the afternoon, most likely by 12 midnight or 3 a.m., the lactates return to normal in the donor. I hope that was the question. I thought I saw something too. Is that the answer appropriate?
I think so. You want target to normalize the lactate values at the end of the procedure.
You really can't target to normalize. You can only try to make sure you are doing everything to prevent it from rising, which is maintaining mean arterial pressure, perhaps by or using the use of non-lactate containing IV fluids. And that's about it. The surgeon then, doesn't do any more Pringle, or he's careful and the surgical resection is completed uneventfully. You will not be able to do anything much more than that.
So what is the usual fluids for the donor in the intraoperative period?
I think my colleagues would agree, most of us just use plasma light these days, unless there is some electrolyte abnormality that you specifically wish to address.
Okay, ma'am. Dr. Rajesh, has he come? Is he available now? Dr. Rajesh?
Yes, hello, sir. Hello.
Hello, Dr. Rajesh, any comments?
I think, as Madam said, I also feel exactly the same.
Okay, and there is another question. What vasopressor is started?
Noradrenaline is the usual one. First we start.
Okay, any questions with regard to Dr. Sindhu's talk lecture? I can't see any comments or questions.
Perhaps we can look at them at the end of the session if they have.
Yeah.
Or there are questions coming in.
Sindhu, what pre-op investigations will you prescribe on the day of surgery?
Day of surgery at our institute, we do everything. Actually, we start from CBC, PTINR, fibrinogen levels. We do the renal function tests, liver function tests. All the tests are repeated on the day of surgery. And once a patient is in the theater, we do arterial blood gas, including we do the markers of infection, CRP and procalcitonin also on the morning of surgery.
You mentioned about the 50,000 as a cutoff value for.
Yeah, we that is like it is mentioned in books that we need to have a value of platelets at least above 50,000, but because otherwise the risk of bleeding will be high. But we do take up patients with even 28,000 platelets, but we give platelets at the time the patient comes into the theater and not transfuse before the surgery. Madam will have some comments about platelets, I think.
Yeah, I think we try 50,000, but there are some patients who may remain in the range 25, 35. So I think I would just look if a person's platelets have been low. I'm happy if it's somewhere above 20, but would take the precaution to run SDP at the time of intubation, because the half-life of platelets is low and you would like to give it as close to induction and intubation as possible. And then by that time, we actually reach out for those dynamic tests of coagulation. And sometimes the dynamic test may not be so bad as the actual numbers show. I hope the audience, it's making sense. Please feel free to ask questions to allow the session to be interactive. If there's anything, I can see a few more questions. Rajesh, would you like to ask them and then get Sindhu to answer?
Dr. Sindhu.
Rajesh sir, it's better to take the questions on the end of the session, no? Okay. So that end of the session, we will allow all the participants to unmute and ask directly. That will be easier, no? So.
Okay. Okay, in that event, we'll go to the next talk. Next lecture by Dr. Eka.
Share screen. Share screen. Just give me a minute.
Okay.
Okay, can you see my screen?
Yes, it's very clear.
Okay. Good evening, everybody, and thank you for giving me this opportunity to speak on this topic. I'll be speaking on intraoperative considerations in liver transplant. And my intended audience are the anesthesiology postgraduate students. I would like to do my talk under these headings. I want to talk briefly on the surgical steps because then only if the context will be ready for my further talk on hemodynamic monitoring. And then I will talk on coagulation monitoring and blood transfusion practice that we follow. Then I will touch upon the 3 stages of liver transplantation surgery, trying to highlight the issues that we have to face in each stage and how to manage the problems. The surgical steps briefly are these. The surgeon puts a reverse L-shaped incision on the abdomen and he dissects the liver free from its ligamentous support. He also separates the vascular connections and the bile duct. The hepatic artery goes first, it's followed by portal vein division, and then lastly, the hepatic veins. Then the liver is free to be explanted, and a new liver is placed in the same position that's called an orthotopic position. Next, the vascular supply is reconnected. The hepatic veins are reconnected first so that the outflow is established before we open up the inflow by connecting the portal vein. After the reconnecting the portal vein, we go on to anastomosis of the hepatic artery and the bile duct. So these are, in brief, the steps that the surgeons do in a liver transplant. This picture shows the same steps. In here, it's a right graft, liver graft, and you can see the draining vein, the right hepatic vein is anastomosed to the IVC first. This is followed by portal vein anastomosis. And then when the blood is allowed to perfuse the liver, the new graft, the reperfusion, that's a reperfusion state. Next comes the hepatic artery anastomosis, followed by the bile duct anastomosis. When we talk about the surgery, two terms we often hear are the classic technique and the piggyback technique. A small note on what this means. Classic technique is when the liver is taken out of a deceased donor. When you take the liver from the deceased donor, the corresponding part of the IVC where the hepatic veins drain are also taken. So it's an en bloc. It's taken en bloc from the donor. And in the recipient, when you take out the deceased liver, that part of the IVC that is that's taken out along with the liver. Now the donor liver with its IVC is placed in this position, and it becomes easy for the surgeon to do the anastomosis. The donor IVC, which is taken along with this donor graft, is anastomosed. So you can see the anastomotic line. Superiorly, it is anastomosed to the recipient's IVC, and inferiorly also, it is anastomosed. So the continuity is re-established. So the problem here is that to do this, the recipient's IVC has to be completely cross-clamped, which means that there might be hemodynamic instability. To overcome this problem, the piggyback technique is being adopted now. Here, from the deceased donor, the liver and the IVC is taken as before, but when you anastomose to the recipient IVC, it is anastomosed end to side. Here it was end to end. Here it is end to side. So this is end to side anastomosis. The other end of the donor IVC is just strictured off. It's closed off. So this is the piggyback technique. When you come to the living donor, of course, you cannot take the IVC of a living donor. Here, what is done, if you're taking the right lobe of the liver, the draining vein, which is the right hepatic vein, is divided. And this right hepatic vein is anastomosed to the recipient IVC. For this, you don't have to fully cross-clamp the IVC of the recipient. A side clamping would be sufficient. So that is the advantage. You need to side clamp only in piggyback techniques. If it's a left lobe, it's a left hepatic vein that is anastomosed to the IVC after side clamping the IVC. So this prevents a lot of hemodynamic instability that would otherwise have occurred if you needed to fully cross-clamp the IVC. Coming to anesthesia as such, of course, it's a balanced general anesthesia that we need to give. We have to remember these CLD patients are very fragile patients, and their physiology is, we can say, balanced on a knife edge. They have a high cardiac output, but they're so much vasodilated, and they may have their circulating volume. It's not it's also compromised. The effective circulating volume is less. And they may have underlying cirrhotic cardiomyopathy. They may be on beta blockers, they may be on diuretics. So they are very fragile in their balanced situation. So our induction also has to be tailored to each individual patient and it has to be titrated. But if the patient is having a tense ascites, or if the patient is having gastroparesis, you have to go for rapid sequence induction. It goes without saying that we need good peripheral venous access. At least 2 wide bore access should be present. Minimum 2, or you should have more than 2, actually 3 would be good. And a central venous access of 8.5 French or 9 French would be a good help. If we need to give rapid transfusion because of the large amount of bleeding, this will be very, very helpful. Invasive hemodynamic monitoring with the arterial line and central line is mandatory. At site, we should have the facility for at site monitoring of coagulation and also appropriate correction of coagulation abnormalities. This means we should have a very good blood bank support as well as the hematology lab support. As soon as we send the lab reports, we should have a good, short turnaround time. The results should be back with us as early as possible. Acid-based and electrolyte status monitoring should be done hourly, so we can keep track of the electrolyte levels and correct it as early as possible. Temperature maintenance is important. We should use a hemotherm and fluid warmers to make sure the temperature remains at least over 35, because as the temperature falls, the clotting process will be affected and the strength of your clot can come down. You should give special attention to maintenance of temperature. Pressure point protection should be looked into because it's going to be a long surgery. So many patients can have issues after the surgery if pressure points are not protected adequately. So I said I'll be doing this talk under separate headings, and one of that main heading is hemodynamic monitoring. We have to monitor certain parameters such as the CVP, the invasive blood pressure, and also the cardiac output, the systemic vascular resistance, the stroke volume variation, or the pulse pressure variation. The stroke volume variation and the pulse or the pulse pressure variation will show us the fluid responsiveness of the patient. So how are you going to do this? Of course, central line and arterial line are a given. That is put in all these patients. The other options for measuring the cardiac output or the stroke volume variation are using a pulmonary artery catheter, or using flow track or Vigilio or other pulse contour monitors such as Lidco or PICO, and Transephasial Echo. Which among these three you will use depends on the availability. And mostly in most centers, it's a pulse contour analysis that is used for continuous cardiac output monitoring and the stroke volume variation monitoring. PA catheters and Transephasial Echo will be used in special situations where will give us added information. Now, blood pressure monitoring, invasive blood pressure monitoring is mandatory. So is it a radial or the femoral that we will use? Femoral, of course, because in situations where there are severe vasodilation, such as that occurs after reperfusion, when there is a severe vasodilatation, the distal vessels, distal arteries can go into spasm because they're very, very sensitive to the presence of catecholamines. So the flow in them tends to come down. When the flow in them, such as a radial artery, so distal artery, when the flow in them comes down, the pressure that is recorded also will be low. The femoral pressures would be more representative of the actual pressure. And interestingly, the NIBP seems to mirror the femoral pressures more closely than the radial. What about the CVP? Central line, CVP, if you have a central line, we can get the CVP values. And if you are using a pulmonary artery catheter, we can get the pulmonary artery occlusion pressure. Now, here we have to remember that these are static pressure measurements. And these static pressure measurements do not equate to the end diastolic volume or to fluid responsiveness. So are they not useful? Of course, they are useful. But if the CVP is high, it indicates that the back pressure on the new liver that we're going to place will also be high and lead on to hepatic congestion, which is something which we don't want. So CVP is really useful in that way. What about the pulmonary artery catheter? It's a gold standard for cardiac output monitoring. So it's a very useful monitor to have, but again, another advantage is that if you have a pulmonary artery catheter, we can directly measure the pulmonary artery pressures, especially if you have a patient whose pulmonary artery pressures on the higher side. PAZ is a good choice, it's a good monitor to use. But the disadvantage is that because of its invasive nature, the complications may be higher in people who are not routinely using it. And its accuracy tends to depend on the user's technique. And more than that, when you need at most, like at reperfusion, a lot of cold blood is going to come into the heart, and this may lead to underestimation of the cardiac output by this pulmonary artery catheter because it's dependent upon thermodilution techniques for its estimation of the cardiac output. What about the next one, the pulse contour analysis? Continuous cardiac output monitoring can be done with a pulse waveform analysis. So you don't have to put in a pulmonary artery catheter to monitor the cardiac output. This is a definite advantage. The monitors that are available are PICO, LIDCO, and FlowTrack or Vigilio. Now, PICO needs external calibration. External calibration in the form of a cold saline flush. So that is not you have to keep on repeating this external calibration. Whenever the patient's resistance or compliance changes, then you have to calibrate again. The same goes for LIDCO, where the lithium dilution technique is followed. It also needs external calibration. So if the patient's resistance or compliance changes in between, then again you have to recalibrate. So you don't know when it is going to change, and you don't know when it has changed. So when will you calibrate? That is a question here. Now, the advantage with FlowTrack or Vigilio, which we use in the institute, is that you don't have to do an external calibration. The calibration is self-calibration. Internal calibration is going on every 20 to 60 seconds. It has got a constant called chi constant, which factors in the resistance and the compliance, and it automatically calibrates, self-calibrates. That is the advantage of using FlowTrack or Vigilio. So there's some controversy regarding the dependability of the cardiac output that is measured by these methods in liver transplant in severely vasodilated patients. There is no doubt about the fact that it's very useful when you talk about the pulse pressure variation or stroke volume variation. Because when there is a positive pressure ventilation, the amount of blood draining into the heart is going to be less. The stroke volume comes down. And so does when the thoracic pressure goes up, the amount that is draining into the heart comes down. When the amount that is the venous return comes down, the stroke volume comes down. And when the stroke volume comes down, the pulse pressure comes down. So the magnitude of fall is related to the preload and the positive pressure ventilation. And the use of vasoconstrictors does not change this variation. One thing that you have to remember is if you're going to depend on this method, the tidal volumes have to be at least 8 to 10 ml per kg, and there should not be any spontaneous breathing efforts. So this helps assess the fluid responsiveness. The magic number of 10 to 12% is there. If the values are over 10 to 12%, then it means this patient may respond to fluid boluses and the blood pressure would rise. The last one in this hemodynamic monitoring method is Transephasial Echo. A Transephasial Echo is very helpful. It's very useful because it allows us to visualize in real time the preload of the ventricles. So if we can optimize the preload very effectively. If there is hypertension, then you can look for cardiac causes, a myocardial dysfunction. You can look for regional wall motion abnormalities. You can look for pulmonary embolism. These are the advantages of Transephasial Echo, but again, limitations are there because it requires significant training, and there's also the possibility of esophageal variceal rupture if they are of high grade. Grade 1 or 2 may not be a problem, but anything higher may rupture, and the surgeons are not very happy with the presence of a Transephasial Echo. And also another disadvantage is that its ability to assess the pulmonary artery pressures may be low, and the views that you can get in this particular situation may also be limited. The best monitor would be, as you all know or would have realized, is that experienced provider who can integrate all the data input that we are getting. So let's move on to the second subheading in our topic discussion, that is about bleeding and transfusion. We all know that liver transplant is historically associated with large amount of bleeding, but with the advancement in surgical technique and anesthetic techniques, the bleeding has come down remarkably. Liver is closely associated, intimately associated with the whole process of clotting. In primary hemostasis, in coagulation, in fibrolysis, and all of this, liver plays an important role. If you look at primary hemostasis, the platelet numbers are controlled by the thrombopoietin that is produced by the liver. So in liver disease, the thrombopoietin level comes down and the platelet number can come down. Of course, there are other factors which contribute to the slow platelet, one being the huge spleen. but still the thrombopoietin plays a major role. Liver produces this ADAMTS13 protein. What does it do? It breaks down the von Willebrand factor, which helps in activating the platelets. So if you look, like, von Willebrand factor is being produced by the endothelium, from the endothelium. So this von Willebrand factor has high levels in cirrhotics because the ADAMTS13 protein, which is produced by the liver, has come down, allowing the von Willebrand factor to be there for a longer time. So though the platelet numbers are less, the ADAMTS13 also being less makes sure that the platelets are highly active. What about coagulation? All the clotting factors are produced by the liver, and also except factor 8, of course. And when you look at the anticoagulants, antithrombin 3, protein S, protein C, they are also produced by the liver. So when there's a liver disease, the clotting factors are reduced. Also, the anticoagulants are reduced. This means there's a new balance struck in liver disease. Just like a new balance was struck in primary hemostasis by having a low platelet but high activity of these platelets, a new balance is struck in the clotting process also. When you come to the fibrinolysis, again, the plasminogen, which is produced by the liver, is less, but again, antiplasmin, that's also less. So again, there's a balance. The thrombin activatable fibrinolysis inhibitor levels comes down. Now in fibrinolysis, the endothelium also plays a part, and you can see here the tissue plasminogen activators produced by the endothelium. Their levels remain high. Now restriction of this happens in the liver. So if the liver is diseased, their levels will be very high. Plasminogen activator inhibitor levels also stay high. So in short, this is what happens. In normal hemostasis, you have so much of procoagulants and so much of anticoagulants. And when there is a liver disease, what happens? The amount comes down, but they come down almost in proportion, so that it's a new balance that is achieved. And this means that there's reduced reserve, which again means that the tip towards bleeding or thrombosis can happen with the slightest insult. An infection somewhere or a renal failure can tip this balance. And the greatest tipper of the balance would be a surgery. Liver transplantation surgery can greatly disrupt this balance. And intuitively, and we think that whenever there is a risk of bleeding, as there is obviously in a cirrhotic who is going to undergo a major surgery, a knee-jerk reaction may be to give large volumes of products so as to prevent any bleedings, to preemptively prevent the bleeding. But that's wrong. That's a wrong reaction. Too many units transfused will lead to an increase in morbidity. If you're going to give a lot of PRBC, which are devoid of coagulation factors, you're going to lead on to dilutional coagulopathy. If you're going to give a lot of FFP during the dissection phase or the initial phase, then you're going to increase the portal pressures and you're going to increase the bleeding again. If you're going to give too much platelets, these platelets may go into the new liver's endothelium and get attached to the endothelium, get sequestrated in the new organ, the new graft, and cause or worsen the ischemia reperfusion injury that can happen here, because it can activate, it can upregulate the pro-inflammatory factor release. So you can see it's not a good idea to give too much. We can use cell saver and reduce the allogenic PRBC transfusion, but remember again, when you use cell saver and give this blood, it is also devoid of any coagulation factors. So it doesn't solve any problem. That particular problem is not solved. So we have, we'll enumerate the problems of large volume transfusion as dilutional thrombocytopenia, citrate toxicity and hypercalcemia, hyperkalemia, hypothermia, immunosuppression, and immunomodulation. Now, so we cannot give too much, neither can we give too less. So on what can we depend? What is our guidance? The guidance is from viscoelastic tests. The two important viscoelastic tests that are used now are rotational thromboelastometry and TEG, or the thromboelastography. Now, if you use this, we get an idea about the kinetics of clot formation. That's the process of clot formation, and its physical property, that is its strength. So we can get these idea if we use these two tests. Now, this TEG, so what we're trying is for a targeted management of coagulopathy when we use TEG. In TEG, what we do is we take the recipient's blood in a cup or a cuvette, and this blood is activated. And into this activated blood, we have a pin suspended, a pin which is freely suspended in this activated blood. And the cuvette starts to move. Initially, this movement of the cuvette is not transmitted to the freely suspended pin because the blood is in the fluid state. And as the clots start to form, the spin gets linked to the cup, to the walls of the cup. So when the walls of the cup move, the pin is dragged along with the cup and the pin starts to move. And this leads to this formation of the graph, the typical graph that you see here. So this method also has got its own problem because that it does not take into account the contribution of endothelium to this clotting process, nor does it take into account the flow related contribution to the clotting process. But this is the best that we have now. And if you look at this graph, you can see there's an arc time. What does the arc time tell us? It tells us the time it takes for a clot to start forming. So it's a latency. It gives an idea about the latency period. If the latency is long or the arc time is long, it means it's taking a long time for the clot to form. It may be because all the coagulation factors are less and needs to be supplemented by giving FFP. So that is why this is called targeted management of coagulopathy. If you look at the next value, that is K, K stands for kinetics. Now, what does that mean? Kinetics means it indicates the speed with which the clot forms. So if the clot is forming very fast, the K will be short. If the clot is taking a long time to, to build up, so if it's taking a long time to build up, then the K is going to be smaller. So K indicates the speed with which the fibrinogen is forming and the speed with which the polymerization of fibrin is happening. And alpha angles also gives an indication of the same thing. The kinetics are the speed with which it's building up, the clot is building up. What about the strength of the clot? That is dependent upon the MA or maximum amplitude, and main contribution is from the platelets. So if MA comes down, you have to give platelets. And if the R or the K comes down, you know that we have to supplement with cryoprecipitate containing, fibrinogen containing product, which is cryoprecipitate. Moving on to the next thing, that is platelet numbers or the value of the platelets, the fibrinogen levels, and prothrombin will also help us in a guidance, but we must realize its limitations. It is just a number which shows its level. It does not tell us anything about the interaction between the other factors and the final result. So we can use TEG or ROTEM, but complement it along with fibrinogen levels and platelet count, the importance being more for the TEG and the ROTEM results. A surgeon's experience, anesthetic management of the bleeding, the whole bleeding process, and the donor graft status, all are very decisive factors in bleeding in liver transplant surgery. Do we have any working guideline as to how much, in what proportion we should give our products? We don't have, so there's institutional variability in transfusion practices. Roughly, they say that if you give 2 units of PRBC and a unit of FFP along with 200 ml crystalloid, or if your crystalloid use is like too much, then maybe 5% albumin, that's a good way to replace products or the blood loss. But remember, there's no guidelines that you can stick to. Just remember that 1 PRBC in a normal person can increase the hemoglobin by 1 gram percent, and 15 to 20 ml per kg of FFP can increase the coagulation factors by 30%, and 10 to 12 units of cryoprecipitate can increase the fibrinogen level by 100 milligram per deciliter. And so there's no way you can know how much, when you transfuse these products, the numbers are going to go up, because there's ongoing loss. So, and you cannot tell how much is going to go up. And platelets, if you give a apheresis platelet, the numbers can go by 30,000, but still you cannot predict because there's ongoing loss. There's a spleen there, which is going to trap the platelets that you're going to give. So you have to have, it's institutional practice varies. Also remember that we said, when we talked about TEG, we said if R prolongs, you give FFP. If it's a K that is it's abnormal, you have to give cryoprecipitate. Remember the difference, the cryoprecipitate and FFP use cannot be interchanged because FFP contains less fibrinogen. 200 to 300 ml of FFP contains only 700 to 800 milligram of fibrinogen, whereas just 10 to 20 ml, that's 1 unit of cryoprecipitate itself, contains 150 to 250 milligram of fibrinogen. And cryoprecipitate contains a lot of factor VIII, von Willebrand factor, and factor 13. So cryoprecipitate is what we should give if there is a prolongation in K or the alpha angle. And you can roughly say we can try to target a hemoglobin of 7 to 9 gram% in your recipient, an INR of 2 to 3 or a little above 3. Cryoprecipitate we can target so that the fibrinogen level remains around 100 milligram per deciliter. This is wrong, not per ml, it's deciliter, 100 milligram per deciliter. And platelet you must try and keep around 50,000. But after having said this, best target is a combination of all your assessment, ending with the operative field, and you should communicate with the surgeon. Operative field, if you look at the operative field and there's no bleeding and your numbers say otherwise, or your text says otherwise, you have to believe what is there in the operative field. The final part of my talk is on the 3 stages of transplant. There's a pre-anhepatic phase, there's an anhepatic phase, and there's a Neo Hepatic Phase. In the pre-anhepatic phase, that is, involves the mobilization of structures around the liver and the porta hepatis. This is also called the dissection phase because this mobilization means a lot of dissection is going on. Then you divide the hepatic artery and then bile duct. So what happens here? Here, in a coagulopathic patient, you're doing a lot of dissections. And depending on the underlying surgical issues, you may land up with heavy bleeding. For example, if you here, this is CT of a patient. In this patient, there's a superior mesenteric vein. There's a superior mesenteric vein and the splenic vein. And after that, you're not seeing the portal vein. So there is a thrombus here. And the portal vein is replaced with a lot of small vessels. So there's a cavernoma formation here. It is as a CP4 disaster, it's going to bleed. What about this? Here you can see in the CT a liver surrounding this IVC, and this part of the liver is closely wrapped around this IVC. The caudate lobe is wrapped around the IVC. And to remove this diseased liver, you have to dissect this part out from the IVC, another potential bleeding situation. Here, what is happening here? This is the portal vein, which is so narrow. What about these? These are the big collaterals that you're seeing. So this is again an area which can bleed. The dissection of this area can lead to huge bleeding. So the pre-anhepatic phase problem, it is easy to see what the problems are with surgical dissection in coagulopathy. And if you're giving over-treating with fluids and blood products, increasing the bottle pressures, the bleeding is going to be a lot, which will lead on to hypertension. Even otherwise, there'll be hypertension because with ascites decompression, recollection of the ascites, which is being sucked into your suction jar, and your manipulation of the liver, pull on IVC, all this leads to hypertension. So how do you manage this? You have to judiciously use IV fluids. You have to judiciously use your vasopressors and your products that's available blood products. A reduction of CVP might help because reduced CVP reduces the portal pressures and your engorged collaterals collapses a bit and reduces the surgical venous bleeding. And how can you reduce the CVP? By volume restriction and use of diuretics such as mannitol. What happens in the anhepatic phase? In the anhepatic phase, the portal vein is divided. That is the start of the anhepatic phase. And after that, the hepatic veins are divided, and then the explantation of the native liver, and then a new liver is placed. And then the start of the caval and portal anastomosis. Now here, what is the problem? Once the portal vein is divided, the blood supply to this liver, the old liver, is no more there. Whatever amount of clotting factors that this diseased liver is producing, even that is not there. So there is severe worsening of the coagulopathy. And also, because there's no liver, even the diseased liver, to metabolize the calcium, there is progressive hypocalcemia. And because of this, there is reduced gluconeogenesis, there is increasing serum lactate and worsening metabolic acidosis. So how you have to treat the coagulopathy that is happening here, you may have to continuously give FFP, and the calcium levels have to be checked, and the calcium has to be supplemented. And the metabolic acidosis that is developing because of the rising lactate in the absence of liver, you have to correct it with bicarbonate administration. The last phase is the Neo Hepatic Phase. The Neo Hepatic Phase starts when when your new liver that's placed inside is the portal vein is anastomosed. When the portal vein is anastomosed and it opens up, blood enters this liver and the Neo Hepatic Phase starts. So what are the problems that you will see in the Neo Hepatic Phase? The first thing that it's a reperfusion syndrome. It may happen in up to 60%, you might even see this reperfusion syndrome. So what's happening here? Actually, you will see a fall in the blood pressure. The mean blood pressure may fall by as much as 30. But actually, this is the definition of reperfusion syndrome. If the mean blood pressure falls by more than 30% below baseline, and that happens within 5 minutes of reperfusion and lasts for at least 1 minute, that's called a reperfusion syndrome. Why does the reperfusion syndrome happen? It is because the metabolic products from the ischemic liver graft, as well as the preservation solution that is used to flush this graft, and microemboli that might be present, all this cold, acidotic, hyperkalemic, vasoactive material-filled blood reaches the heart and goes into the systemic circulation. So there's a sudden preload increase, and there's an abrupt increase in the hydrogen ion concentration and the potassium concentration, and the other vasoactive substances and emboli are released, leading to a rise in the CVP, a fall in the systolic pressures, a fall in the systemic vascular resistance, and even a rise in pulmonary artery pressures. There might even be bradycardia, arrhythmia, and even arrest. So it is a serious problem. So how do you manage this? Before the reperfusion, you must make sure all your baseline values are fine, that your calcium levels are normal, your acidosis, if there is acidosis, it should be treated with bicarbonate. And you should try to fill up this patient. Till now, if you were following a volume restricted pattern, now is the time to fill up the patient and keep your vasopressor agents ready. Your vasopressor agents would already be flowing, but make sure you have additional vasopressor agents to be given as bolus, either phenylephrine or norepinephrine, or when pushed to the wall, epinephrine should be ready. In Neo Hepatic Phase, after the reperfusion, you will see that somewhat increased the bleeding tendency is seen. And this is because the platelets are getting entrapped in the new liver, in the endothelium of the new liver is trapping this platelet and sequestrating the platelets. There may be, it'll take time for the new liver to manufacture the coagulation factors. So there's low levels of coagulation factors, and this new liver may release endogenous heparinoids from the endothelium. And there will be a hyperfibrinolysis also in this stage. This hyperfibrinolysis may be a problem which starts in the anhepatic phase, and this you can tackle by starting tranexamate in the anhepatic phase itself. Afterwards, now the next steps will be the hepatic artery anastomosis, biliary duct reconstruction, and if you have a good graft function, you can see the production of bile on the table itself. And the serum lactate starts to come down, there's normalization of serum calcium, and resolution of the cardiovascular system instability. Now, if your quality of the graft is not so good, if it's questionable quality, or if you have a delayed function of your graft, or you have primary non-function, then the scenario is not so good. You have bleeding, continuous bleeding post-reperfusion, your calcium levels stay low, you have cardiovascular instability, your lactates remain high. So that's a bad scene. Anyway, in all three phases of surgery, you must give attention to your coagulopathy management of coagulopathy. Your fluid in the initial two phases, you would restrict your fluid administration. You'll be judicious. You would manage the serum electrolytes by closely monitoring the values and supplementing as required. If the potassium values are high, you would give GI bolus to limit it, because at reperfusion, it's going to go even higher. You don't want a high potassium value. Actually, a value around 3 is, you'll be very happy with the value around 3 at the time of reperfusion. In the anhepatic and neohepatic phase, fibrinolysis can develop, so tranexamate should be started. And pay close attention to maintenance of temperature. Do not neglect that, and the acid-base balance. After all this, patient can be extubated after a brief period of overnight ventilation. This is a long surgery, so overnight ventilation and extubation. Some people do talk about fast tracking, but then you have to have the right kind of patient, and it should be a smooth surgery. a recipient who's not sick to start with or low MEL patient with a smooth surgery may be a candidate, but at present we ventilate them overnight, giving them time to settle so that if any complications happen, it happens with tubing, and we have more control over factors. So in my lecture, I talked about the surgical steps in brief. I talked about coagulopathy, monitoring of coagulation, and its management. I talked about the hemodynamic management, and I concluded with highlighting the problems that we face in the three stages of liver transplant surgery. I thank you for all your kind attention, and I conclude my talk.
Dr. Rekha, you want to answer the questions in the chat box, or we'll take it at the end of after the?
Yeah,
Dr.
I think that was a consensus. I think we'll take it at the end.
Okay. We'll now go to Dr. Subair for the post-operative aspect of recipient.
Hi, good evening. Am I audible?
Yeah. Yeah.
Great. Hi.
Thank you.
Okay, let me share my
the
screen.
slides.
It was supposed to be here. Okay. Okay, can I see my screen?
Yeah, but slides hasn't come.
Is it coming now?
And not yet.
Oops. I can see it on my screen. Stop share and try again.
Okay.
Share screen.
Yeah, now it has come.
Is it fine?
Yeah, it's fine. It's very clear.
Yeah. Okay, brilliant. Okay. First of all, I would like to thank the organizers for giving me the opportunity to take part in this teaching session. So in the next 20 minutes or so, I will try and quickly skim through rather to what happens in the immediate post-operative period in these patients after they complete their liver transplant surgery. Now, the goals of care. The goals of care as in these patients, as you would expect in any post-surgical or in any surgical ICU, is monitoring and achieving homeostasis. And the two specific ones that are relevant to this particular set of patients are the evaluation of the graft function, as well as making sure that they get the right immunosuppression. Right, now we're going to have a system-wise approach as to what we do as far as monitoring and achieving homeostasis is concerned. And as far as this talk is concerned, I'll stick to what happens in the first week, 10 days or so. If they do develop complications and stay for a longer period of time, or if they have to get readmitted in intensive care, that will be something that's beyond the scope of this presentation. So we'll go through what happens in the first few days initially. So cardiovascular and hemodynamic issues are by far the most common problems that these patients have. Now, these are usually more prevalent in the first couple of days. So as Raga madam had said earlier, so they do get ventilated overnight because we try to achieve a degree of hemodynamic stability in these patients. Now, given that they've had a major surgery with a lot of fluid shifts and blood and product transfusions and fluid transfusion, they tend to have hypertension, and it will be usually a combination of hypovolemia plus vasodilatory and circulatory failure. So what do you do? How do you treat them? Just like how would you treat any other hypertensive patients? You look at the heart rate, blood pressure, examine and look at the capillary refill time, see the peripheries are cold, look at their input, flow volume input and output chart, look at the urine output, drain outputs, the lactate, the base excess. If you've got access to an echo machine, look at the left ventricle, the right ventricle, the IVC collapsibility. And if you've got a cardiac output monitoring, look at the cardiac output. And simultaneously, a lot of times we, along with the volume loading, with usually colloids in these patients because we tend to have a low threshold of using albumin along with crystalloids as well. And we assess the coagulation parameters in these patients. And most of the time they will require supplementation of coagulation parameters, usually FFP and cryoprecipitate, and if the hemoglobin is low, the PRBC as well. So the hypotension, circulatory failure, the hypovolemia, circulatory failure usually go in tandem, and it is usually a dynamic thing, and we correct it based on static as well as dynamic parameters of volume responsiveness and coagulopathy. Now, to have myocardial dysfunction along with it is not really common, although not unheard of. So you do get the occasional patients who tend to develop global LV dysfunction, or you can have the problems of protopulmonary hypertension in these patients, which is something to bear in mind. So we need to rule out those issues as well. Hypertension is not really that common, although we do get the arrhythmias, most often being atrial and ventricular arrhythmias. The management of that is pretty similar to how you treat any other arrhythmias, electrolyte imbalance correction, volume correction. And then if it comes to drugs, we need to bear in mind that amiodarone, which is one of the most commonly used drug, is hepatotoxic. So that is something to bear in mind. Coming to a brief description of the specific issues, we mentioned briefly about the portopulmonary hypertension. If they do happen, they not usually happen the first day or so. It could be about 3 or 4, 5 days later if they did not have it pre-operatively. Or sometimes, as Madam had mentioned, you can develop it intraoperatively, and very rarely they do develop it only post-operatively. And if it does come to that, the management involves clearly oxygen supplementation, trying to offload the heart. So you give them diuretics, you give them drugs to decrease the pulmonary hypertension. So you give them phosphodiesterase inhibitors like your sildenafil. You give them endothelin receptor antagonist like bosentan, ambrisentan, and then and then the role of calcium channel inhibitors is a bit problematic in these patients because usually the blood pressure will be low as well, and plus they are not known to have endothelial reactivity to the calcium channel blockers as you would expect with other pulmonary hypertension patients. Now, worst comes to worst, it can be a life-threatening situation. You can go to heart failure and patients could die. So procedures like atrial septostomy and lung transplantation in these patients have been documented, but those are extreme situations and you probably wouldn't see them at all, if not once or twice in your career. So following hemodynamic issues, the next one is pulmonary issues. Now, in these patients, as you could see in the slide, about a third to almost a half of these patients do have pleural effusion, which is understandable given that most of the chronic liver disease patients have got ascites. And during the surgery, you dissect out the liver and along with that you open up the lymphatic channels. There is a lot of fluid that goes from the abdomen to the other side of the diaphragm, and the right side of the effusion is fairly common in these patients. The atelectasis after a prolonged surgery and the acute respiratory distress syndrome, the volume overload issues, a lot of using blood volume replacement, etc., can have acute lung injury. So these are fairly common. However, they do settle down most of the time, and the crucial factor is that the liver has to start functioning. Once the liver begins to function, you would find that they recover dramatically very well. Now, to develop pulmonary edema, again, on someone on positive pressure ventilation whose heart has been reasonably evaluated pre-operatively is not uncommon. However, there are the occasional cirrhotics with cardiomyopathy that gets uncovered in these situations, and you occasionally develop such problems. Now, to develop pneumonia in the first couple of days is fairly uncommon. However, towards the end of the week, you can see infection, sepsis settling, and pneumonia could be one of them. So that is something to bear in mind. Now, the renal issues, almost depending upon which series that you look at, about 20% to almost 95% of people have got renal dysfunction. Now, there are preoperative factors that contribute to it. As Dr. Sindhu had mentioned, in the high proportion of patients have got hepatorenal syndrome. Many of them are on diuretics. And then in the intraoperative period, they've got risk factors like volume loss, hypertension, use of blood products. And the post-operative period, along with all these risk factors, we give them drugs like the calcineurin inhibitors, the immunosuppressants that have got an increased risk of nephrotoxicity. So there are pre-operative and post-operative factors that contribute to the renal dysfunction. And and similar to what I had mentioned earlier, after the first couple of days, if the liver continues to function properly, most of these settle down. A small proportion of these patients would require terlipressin to continue the preoperative use, basically to decrease the splanchnic, decrease the volume, the portal hypertension, and the splanchnic pressures. Now, as far as the electrolyte imbalance are concerned, you will find just about any electrolyte imbalance that is documented in the textbook in these patients, the post-operative period. You've got hyperkalemia, hyponatremia, hypomagnesemia, calcemia, hyperphosphatemia. The hypokalemia in these patients are contributed not just by the diuretics, but then you give them corticosteroids, you give them the sugars go up, you give them insulin, the potassium goes down. And some of them will have metabolic alkalosis, and hypokalemia will be contributed again as a compensatory mechanism in these patients. Hypokalemia, if they develop acute kidney injury or secondary to the calcineurin, the tacrolimus that we give them. Hyponatremia preoperatively, again a reflection of the volume status. Hypernatremia to happen the first 2 to 3 days is not very common. However, as a liver, the patients who have been preoperatively encephalopathic, or the ones who have received a higher volume of FFP, because FFP, if you remember, will have a high concentration of sodium in it, almost 165 to 170 millimoles per liter. The albumin that we use has got usually a higher concentration of sodium, unless you use the low sodium albumin in practice. Again, the hypomagnesemia due to the use of diuretics, hypocalcemia to the use of the citrates, and hypophosphatemia. There is some indirect evidence that ongoing hypophosphatemia could be a reflection of the liver regenerating and expanding. So in a living donor setting, when you use only part of the liver and you would expect the liver to grow in size for the next few weeks, to attain the total function, and ongoing hypophosphatemia might be an indicator that the liver is functioning reasonably well. So you correct them, the electrolyte imbalance, as how you would normally correct in any other patients. Neurological issues, again, to have neurological issues in the first couple of days, not really common. And the day after the surgery, or the day on the surgery, we would be sedating them, and we stop the sedation. And had they not been encephalopathic before you start off with, you'd expect them to have a reasonably good level of consciousness, good enough to be extubated, provided the liver works fine. Now, the ones that don't fall into this category are the ones who have been encephalopathic before the surgery, or the ones who have or the acute liver failures, who would take 2 to 3 days for the neurology to improve. If it doesn't improve as you would expect, then you have to look for non-liver causes, i.e., intracranial bleed and other catastrophes in the first couple of days. Now, if the neurology gets reasonably or improves reasonably well to extubate, and then if you find that the neurology doesn't really improve the next few days, i.e., from day 3, 4, 5, even though the liver is working reasonably well, then you need to look into factors like electrolyte imbalances. So hypernatremia sometimes can contribute, and then you can have the neurological complications of calcineurin inhibitors or tacrolimus, which can range from mild tremors to acute confusion, status epilepticus secondary to the posterior reversible encephalopathy syndrome, or the PRES. So these are problems that are specific to the liver transplant patient that you see after the first couple of days. Now, the GI issues. Now, like with any patient with a coagulopathy and the use of steroids, they are at a high risk to develop stress ulcers. So they all get stress ulcer prophylaxis. Feeding, we attempt enteral feeding as fast as possible, as soon as possible. So that, as Raga madam had mentioned, so extubation on the day after the surgery, on the morning of the day after surgery is a norm for us, and a few hours later we start them orally. And we don't force feed them, but we give them food or feeds with high protein content. Usually pre-prepared ones are usually have a high protein content in them, so we give it to them as early as possible. And the short, small set of patients for whom parenteral nutrition is not possible, enteral nutrition is not possible, parenteral nutrition can be considered. Now, a word regarding the ascites management, and now that is a rather complicated situation in the sense that we have to have a close monitoring of the volume intake and the volume output in these patients. Now, as I mentioned earlier, a lot of them would have a high degree of ascites to contributing to maybe 2 or 3 liters per day sometimes. Now, we don't normally go around chasing the drain output of ascites of 2 or 3 liters per day. What we tend to do is to mobilize the ascites using diuretics. So you tend to use furosemide and aldactone in these patients. We also tend to use albumin, 20% albumin, and that is replaced at a rate of about 100 mLs for about a liter of ascites is sort of the ballpark figure that we tend to use. At the same time, we tend to continue to use the crystalloids. As Madam said, plasmolite is the commonly used fluid because it doesn't contain lactate and is a balanced crystalloid solution. But we have a low threshold of using albumin, and usually an average adult would get about 200 to 300 mLs of albumin per day for the first couple of days. Hematology issue has been extensively dealt with, Rega madam. We have a system that favors bleeding and a system that favors thrombosis in the liver patients, and it's usually a balance between these two. Now, in the first few days after liver transplantation in the ICU, it is usually the bleeding that causes most of the problem, and the two main causes for the bleeding are: one, there's been a surgical problem with the surgical anastomosis, i.e. you've got a surgical bleed, or you've got a coagulopathy. So we assess the coagulopathy as was mentioned by Raga madam, and then they do get replacement with blood products, FFP, cryoprecipitate, platelets, etc. Tranexamic acid is fairly regularly used, and the occasional patients do get the recombinant factor 7A, and sometimes occasionally we have used the prothrombin concentrate, complex concentrates as well. A brief description. The first is my slider seen. So, is my slider seen? Probably not. So the first picture of the is normal picture of how the TEG normally looks like in a patient who is not coagulopathic. The one that is below is the one that you'd find one with who is coagulopathic, whose R and K could be prolonged. The fourth one in line is the one with fibrinolysis, and the rest, the DIC, the hypocoagulable ones, you do find them occasionally if the liver is not working as well as you would expect it to. The one on the top, the hypercoagulation one, is not usually seen in the liver transplant patient unless they've got some sort of prothrombotic condition preoperatively. However, as a side note, we do see the hypercoagulable TEGs in the donors, especially in the day 2 and day 3 after the surgery, as has been studied by Dr. Rajesh extensively. So, as far as hematology, as a summary of that, the first couple of days usually it will be the bleeding that is the problem. You need to rule out a surgical cause, and then you need to correct the coagulation if there is no obvious surgical cause. Thrombosis, we'll come to that as a specific liver-specific issues. No, so this is as far as the organ system monitoring is concerned. Now, coming to issues that are specific to the graft and specific to liver transplant. So it can be broadly divided in the initial few days to primary non-function and the early allograft dysfunction. Now, okay, I can't find that. Now, the primary non-function is defined in two ways. So you've got the primary non-function in the whole liver, and you've got a primary non-function in a segmented liver. So as far as Kerala is concerned, or Amrita is concerned, to be specific, we do a lot more of segmented grafts or living donor liver transplantation as opposed to deceased donor where you get the whole graft. So in a living donor liver transplantation, not a segmented graft, you need to have one of the following in the first 7 days as far as definition of primary non-function is concerned. So you need to have an INR more than 2.5, equal to or more than 2.5, a lactate more than or equal to 4 millimoles per liter. So you need to have pH, arterial pH of less than 7.3 or a 7.25 or a venous pH of less than 7.25. So one of these is a criteria for a primary non-function. Having said that, it is fairly common to see these numbers in the first couple of days in a segmented liver graft. However, we don't go rushing to relist them because we see a trend, and over the next couple of days we do find that the graft pick up and the numbers come back to normalcy. And the signs of graft primary non-function will usually be seen right from the theater. So the liver doesn't get perfused well. You do not see bile coming after the vascular anastomosis. You find you do not find hemodynamics getting better. There is no urine output. Coagulopathy worsens. Hypothermia, hypoglycemia, urine output worsens. Acidosis, lactate goes up. So these are all signs of a liver that is not functioning. And if it's a primary non-function, usually you will get a fair idea of what is happening either on table or in the first 24 hours. So which is one of the reasons why we try to keep them ventilated the night after surgery. Having said that, it is more common in the deceased donor setting as opposed to the living donor liver transplantation. So the next thing to be aware is slightly different, but a similar thing called an early allograft dysfunction. Now, this is defined on day 7 post-operatively, and to have to fulfill this criteria, you need to have bilirubin that is 10 or more on day 7. You need to have an INR 1.6 or more on day 7, and you can have at any point in the first 7 days an AST or an ALT more than 2000. So this is the definition of early allograft dysfunction. Now that is not very common in a living donor liver transplantation if the donor is a fit donor. So you've got a young donor that doesn't have steatosis in the liver. You've got a recipient with a low MELD. And because our cold ischemic times are almost negligible in a living donor liver transplantation, we do not have that much problem of early allograft dysfunction unless, of course, the size of the graft is small. So that comes to the question of small for size. Okay. Now, yes. So this is a good diagram of small for size. So you basically have to think about 3 things in small for size. The first thing is that the graft is the GRW, or the graft weight ratio, is less than 0.8, and there is a good portal inflow. There should be, look at the point number 3, there should not be any technical problems, i.e. there is no vascular or biliary anastomotic complications. There should be no infections, and there is no evidence of acute rejection. Along with these 2 points, if you have any of the 4 mentioned in point number 2, so you've got ascites, hyperbilirubinemia in the days mentioned, a prolonged PT, or alteration in cerebral function, that comes on the definition of small for size syndrome. So to put in plain words, what that means is that the graft liver is either not big enough as far as the volume is concerned, or not good enough as far as the function is concerned to do the synthetic functions of the liver. So it is a liver that is not doing its job as you would expect it, and it's small for size either by weight or by function. So that is by definition, in simple terms, what small for size is. Now, what can you do when you get small for size? So you can prevent it by taking a good size graft for the patient. You could make sure that the donor liver is not steatotic, and if that the donor is a relatively young donor. So these are the risk factors as far as the donor is concerned. Now, as far as the recipient is concerned, if there are instances of high portal pressures in these patients, then the marginal donor livers can develop small for size. So what happens is when the anastomosis happens, yes. Where did that go? Yeah. So if you can look at this picture, when the portal anastomosis happens, there's a lot of blood that goes from the portal system into the liver. Now, if a small graft is overwhelmed with such a high volume of blood, develops sinusoidal and endothelial injury, and that graft doesn't function as quickly as you would expect. So there will be a reperfusion injury in this graft. So to try and prevent that, there are modulating techniques like splenic artery ligation, splenectomy, portal cable shunts, etc., that the surgeons tend to do. So these are the things that you could do surgically, pre-operatively, if you suspect small for size. So as far as the management of the primary non-function is concerned, or the early allograft dysfunction or small for size is concerned, from an intensive care perspective, it is all supportive. So you support the organ systems, as mentioned earlier, cardiovascular, respiratory, neurological, renal, feed them as much as possible, practically, and then hope that the liver picks up. If it's a primary non-function, that is an indication to relist and look for another graft. If it's an early allograft dysfunction, you would expect that with these supportive measures, that liver will pick up in size and continue to function over the next few days. And if it's small for size, then you continue these supportive measures and see what happens. There is some evidence to use continuous veno-venous hemodialysis in these patients. Basically, that tends to decrease your bilirubin, decrease your ammonia, and decrease your encephalopathy. And similarly, there's some people who have tried plasmapheresis in the small for size syndromes, but with what you call not very convincing results. So if you get primary non-function or small for size, ultimately they might end up requiring retransplantation. People have tried pentoxiflin, somatostatin analogs, etc., with not really much benefit in this set of patients. Right, now specific surgical anastomotic complications, as I mentioned alluded to earlier. So there are about 5 to mention here. So hepatic artery thrombosis. Now, it is usually a surgical problem. So basically what that means is that so if you look at the picture here, the hepatic artery anastomosis, you've got a clot. So that clot is a problem because the hepatic artery is what supplies the bile ducts. Now, if the bile ducts get ischemic over a period of time, they developed biliary strictures, bilioma, recurring sepsis, and the graft will fail. So you need to treat that. That could be treated radiologically or surgically. If it happens the first 21 days after surgery, that is an indication for relisting, because the long-term outcome of those grafts are not very good. Now, the caveat to mention is that in the living donor liver transplantation, because there's a cut surface and there can be neovascularization, sometimes we do get away with hepatic artery thrombosis, and over a period of time that we do find an occasional arterial trace, and some of them do reasonably well. However, that is an off chance. It is not the norm. Portal vein thrombosis. Portal vein thrombosis, again, usually a surgical problem. If it clots, as you would know, that 60 to 70% of the blood comes from the portal vein, and you've got a clot in there, you need to correct that either radiologically, which can be catheter-directed lysis radiologically, or you have to go back to theater and reanastomose, take the clot and reanastomose. Again, these are emergencies, surgical emergencies in the liver transplant unit. Biliary leak. Now, biliary leak, again, some people describe it as an Achilles tendon of liver transplantation. It can be a long-term affair, problematic, and an indolent affair sometimes. So bile leak, if it's seen on day 1, is usually a bad thing. That means your anastomosis has leaked, has given away, and the biliary anastomosis is usually either bile duct to bile duct, or it could be bile duct to enteric. depending upon the number of the bile ducts that you've got and the length, etc., and the pediatric, etc. So if it's frank bile leak on day 1, day 2, they usually go to theater because you need to fix that surgically. If it is a bile leak that happens slowly over a period of time, day 3, day 4, bit of abdominal pain, bit of bile leak coming out, and then after a week or so, they tend to get an imaging. And if there is a collection there, that tend to get drained percutaneously whenever possible. And the treatment then for the long term is that if the bile leak doesn't settle, you will need to give the bile a pathway of low resistance, because fluid, as you know, flows through a pathway of low resistance. So endoscopically, they get a sphincterotomy. So and then bile continues to flow through the sphincter of OD, and you decrease the pressure within the biliary system. So that is the whole idea behind it. And sphincterotomy doesn't work. They do get a what you call stent, and which might require drainage a couple of times. And you would expect that over a period of time that bile leak will settle, and sometimes they might get strictures. Now, if the bile leak doesn't get settled, then over a period of time again, then that is an indication for bilioenteric anastomosis, i.e. a surgical intervention. Biliary strictures, again, as alluded to earlier, doesn't happen the first couple of days. It's usually a complication of biliary leak or the anastomosis being too tight. Again, usually endoscopically treated, sphincterotomy, stent, and if that doesn't happen, surgery again. Bleeding, so that was mentioned multiple times in the hemodynamic side of things. So if it is an anastomotic problem as far as bleeding is concerned, then they will have to go for surgery if that doesn't settle. Right, sepsis. Now, even though the graph shows what happens the first month, 2 to 6 months, and 6 months, what I'm going to concentrate is the first few days, as I mentioned. So first few days, you're basically worried about gram-negative sepsis, primarily because many of you've had they are immunologically compromised. These patients start off with huge fluid shifts, blood products given. They've had multiple SBPs and other infections previously. They have had multiple dose of antibiotics previously. So gram-negative sepsis, usually with multi-drug resistant organisms, is what we tend to see in the first few days. MRSA not very common here. C. diff not really common the first couple of days anyway. But if they tend to have a longer stay, then either your second bout or the third bout of sepsis, if they do get, could be C. diff. The source of sepsis usually will be bloodborne, and that will be usually secondary to, I'll rephrase that. Cause of sepsis will be abdominal as a source, but then a lot of times they do get bacteremia from the abdominal source, and usually it will be a bile leak or a remnant of very, very rarely they do get a UTI, but it's usually a bile leak that contributes to all of these problems, rather than a line-related problem that these patients get. Fungal sepsis in the first few days, very rare. About after a week or so, you can get the second bout in these patients, because, mind you, as Dr. Siddha has mentioned, we screen them for signs of infection before taking them for transplant. So to have that problem the first couple of days is very unusual, but we do provide them with prophylaxis with fluconazole as a standard. Again, viral infection the first couple of days or first week or 10 days is very uncommon. Some of the drugs that we tend to commonly use, like N-acetylcysteine, prostacyclins, and bile acids, most of the centers use them. However, the evidence base behind or the level of the evidence behind the use of these drugs, as far as the benefit is concerned, is minimal, apart from probably the prostaglandins tend to decrease your chance of acute kidney injury. Right, now just to brush up things as far as an ICU management is concerned, the attention to detail, looking after the minutiae does give a big impact to the outcomes of these patients. So lines and tubes, we tend to take out the lines as early as possible, the ones that you don't require. So as a routine, now as Raga Madam has mentioned, we do tend to have a femoral arterial line and a peripheral arterial line. As a routine, if the liver graft is functioning well and the NR is probably not more than 4.5, the femoral arterial line comes out, unwanted peripheral line comes out. If they have got more than one central line, we just keep one central line. So unwanted lines and the NG tube, they all come out on day one. The drains stay as far till the abdominal drains, I mean, stay for the first 3, 4, 5 days, and once the drain output start coming less, and once we make sure that there's no bleeding and there's no bile leak, the drains come out, because again they're a piece of plastic which can harbor bacteria. As a routine, by about the 5th day, the central line comes out if they do not have any other pressing requirements for the central line. And then by the time they get discharged from the intensive care, on usually about day 6, day 7, they just have a peripheral cannula. The Foley's catheter comes out as a routine on day 3. Pain is usually not much of a problem in the chronic liver disease patients, because many of them have got ascites and they've got a lax abdominal wall. Got pain, that then you need to be obviously treat the pain and look for reasons for pain. And if it is an acute liver failure patients, usually because of the nature that they were encephalopathic to start off with, they will be ventilated for 2 or 3 days for the neurology to get better, and they'll be getting fentanyl during that time. So again, when they get up or when they wake up, pain is usually not much of a problem till you start mobilizing them. DVT prophylaxis, they all get TED stockings, but because of the nature that they are coagulopathic, we don't tend to give Clexane in these patients for a DVT prophylaxis. The use of aspirin or Clexane is not unknown in liver transplant in the immediate post-operative period, but that will be more for a hepatic artery or other thrombotic issues and not for the DVT related issues. So good nursing care, including use of beds that have got that has got cushioning and things like that prevents the pressure sores, and good barrier nursing and good physiotherapy and early mobilization are important in these patients. Again, things that are specific to intensive care is mentioned in this slide. It's very because there's a use of drugs, immunosuppressive drugs, a lot of antibiotics, those supportive medications in these patients. We need to keep an eye on the drug-to-drug interactions. So the azoles, like the fluconazole that you tend to use, the macrolides, the calcium blockers that can sometimes be used for dealing with the high blood pressure that can happen, that you could see from day 4, 5 onwards, because of the use of calcineurin inhibitors and the use of and if you use protease inhibitors in these patients, you do find that they can increase the tacrolimus levels. So it is something that to bear in mind. As a routine, we tend to check the tacrolimus level in these patients from day 3 or 4 onwards, and then look at keep monitoring the levels from twice a week. Try to keep the level between 5 to 8 nanograms per liter. If you use enzyme-inducing medications like rifampicin for whatever reason, or benzodiazepines, then you'd find that the tacrolimus levels do come down. So it is drug-to-drug interaction is an important thing that you need to bear in mind. And as you would have guessed by now, the ones who have not dealt with liver transplantation, it's a team effort, and in intensive care, the nurses play a huge role as far as the rehabilitation of these patients are concerned. Once they get extubated, which is usually by day 2 or the day after surgery, then subsequently they have one-to-one, they need intensive nursing care, and it's always one-to-one. We have a team of dedicated pharmacists, nutritionists, physiotherapists, and allied healthcare staff who look after these patients. A final slide, if the time permits, regarding rejection and immunosuppression. I think almost over time by now. Briefly go through, there are mainly 3 types of rejection that you can think about. Hyperacute, which happens usually on table, and you would recognize that by a liver that is not functioning. You can have the acute cellular rejection, which happens in the first few days and is usually treated with steroids. The antibody-mediated rejection, again, is usually due to the donor-specific antigens in these patients. Then again, these are part of the acute rejection that can happen, although acute cellular rejection is more common. The chronic rejection, again, usually on an OP basis, they get treated unless they develop sepsis secondary to whatever reasons and immunosuppressants, and then they come to intensive care. As for the class of drugs used for immunosuppressants, during the induction phase, we tend to use basiliximab, usually the antithymocyte or the polyclonal antibodies, and ATG or the ALG are not that commonly used now, or the CD52 antagonist, the alentuzumab, is also not commonly used for the liver. So for induction, it's usually steroids, solimedrol or methylprednisolone, and basiliximab that we tend to use on day 0 and on table. And subsequently, we start off the calcineurin inhibitors, combination of steroid calcineurin inhibitors, and slowly pick up on the with MMF for the next ensuing days based on how the platelet levels and the myelosuppression improves. So that is briefly regarding the use of immunosuppressants in these patients. Last slide on long-term issues. And you've got issues with rejection, malignancy, disease recurrence. If say they started off with hepatitis B or hepatitis C and were not compliant with therapy, or primary biliary cirrhosis, or they can have disease recurrence and then come to intensive care with problems regarding to that. Metabolic syndrome, hypertension, diabetes, again, steroids and CNIs are notorious to cause that. Similarly, renal failure, CNIs, or the tacrolimus is notorious to cause them. So these are some of the long-term issues, and most of them tend to get treated in an OP basis, and it's the occasional few ones that have problems with these long-term issues that end up in the intensive care. So with that, I will, I think I've just about exceeded my time. I will stop sharing screen, and I will take any questions if there are. Thank you.
Thank you, Dr. Zubair. Before we take on the questions, there is an important announcements. The next, regarding the next week's program, this is for the postgraduates who are just graduating or graduated, that tips and tricks to placement in anesthesia abroad, because there's a lot of opportunities for postgraduates coming in UK, US, and Australia. So we have faculties from UK, USA, Australia, and our own Baljit Singh sir will be speaking about opportunities for postgraduates after their MD or DNB regarding fellowship programs in India. So this will be a useful program for all the postgraduates. I request the postgraduates to spread the message and request the faculties to encourage your postgraduates to attend these sessions. And can we take on the questions in the chat box? Yeah. I think everyone can unmute and ask questions actually, but we'll start with the there was a question regarding NAC for donor, and Dr. Rajesh has answered in the chat box. It's routinely given for donors in our institution. And another question is, any change in peak airway pressure during anhepatic or Neo Hepatic phase, and how much PEEP in the post-op period? Post-op period, yeah.
So we haven't noticed any change in the peak pressures related to the phases of surgery. It's not seen unless there's some tube malfunction related to phases. No changes in pressures that we've noticed.
Thank you. And another question is combining regional anesthesia, and what sort of regional anesthesia? In recipient.
Recipients, somehow they do not post-op, they do not have so much pain as Dr. Zubair did say. And we are giving a lot of fentanyl intra-op. So they generally do not complain of pain in the post-operative period. It's uncommon. Dr. Zubair can add to that about the post-op pain.
Yeah. So as Madam had said, intraoperatively they get a fentanyl infusion. So that stays in the system. And we tend to ventilate them overnight. So again, they've got enough fentanyl in the system or within their body. Now, on day one, we don't tend to mobilize them. So fentanyl is switched off as a routine around 5 in the morning. So they've already received, almost 12 to 16 hours of fentanyl infusion, or even more sometimes. So once that is done, they are not mobilized on day one out of the bed. So they don't have pain as far as mobilization is concerned. Now from day 2 onwards, we mobilize them on the edge of the bed, get them sitting on chair. Usually for the CLDs, pain is not an issue because most of them have got a lax abdominal wall. Now, as mentioned, the acute liver failures tend to get ventilated for 2 or 3 days till the liver picks up. So they've got fentanyl for the first 3 days. Now, if the chronic liver the CLD patients do develop pain on day 2, day 3, that is something to be wary about. It might be that they've got an incipient bile leak that we tend to observe them closely to see if there's a first sign of a bile leak that is due to come. One thing that I did not mention was that as a routine, they all get ultrasound abdomen for the first 5 to 6 days daily in the morning. So if there are any collections there, that will be picked up. And if there are any vascular or anastomotic issues, they will be picked up as well. And if they do have pain, fentanyl is a go-to drug. So SOS fentanyl usually sorts out most of the issues. For the occasional ones, we tend to use buprenorphine patch, but we have had issues with nausea, vomiting with buprenorphine. So usually SOS fentanyl sorts out the problem. Hope that answers the question.
Yes. And another question is patient with moderate to severe TR, pre-op optimization and post-op concerns.
Patients with TR are actually not a good candidate for liver transplant surgery. It means they have a high pulmonary artery pressures. So if it is just because of volume overload, then that can be taken care of pre-operatively by giving them good diuretics. If it is not because of that, but it's because of high pulmonary artery pressures, then they may have to be given agents which will dilate the pulmonary artery pre-operatively so as to bring down the pulmonary artery pressures. So it's not a good idea to take up a patient with high TR because it's going to harm the liver, the new liver that you're going to place there. It's going to cause venous congestion there.
When you assess the PA pressures, if it is more than 50, that's actually an absolute contraindication. Usually, when the PA pressures come down to less than 35, we can take them at a normal risk for the patient without PA.
Of questions regarding pediatric practice.
Rajesh, actually, this talk was supposed to be on CLD in adults.
Yeah.
So can we restrict questions to that topic?
It's okay. It's okay. So another question is rationale of using intraoperative tranexamic acid, risk of hepatic artery thrombosis postoperatively.
Tranexamic, if you're following up the coagulation parameters with TEG, you can see fibrinolysis sets in during the anhepatic phase. This is because when the liver is out, the tissue plasminogen activator, which is produced in the endothelium, it's actually metabolized by the liver. So the value of the tissue plasminogen activator goes up. And many patients tend to develop fibrinolysis during this anhepatic phase. So that's why that we start tranexamate in this phase. And we generally don't see that causing an issue. And as we are following up with TEG, we can know whether the patient is developing, whether the TEG is becoming prothrombotic. Generally, it does not. So as soon as the field becomes clear and there's no bleeding, we communicate with the surgeons and we take a decision mutually whether we should continue or stop the tranexamate infusion.
It's not continued in the post-op period.
Pardon?
It is not continued in the post-op period.
No, usually we don't. No. Usually we don't continue unless there is evidence of ongoing fibrinolysis, which usually doesn't happen when the graft works.
NAC is continued in the post-op. How long will you continue?
So by routine, it's continued up to 3 days. I would rather say 72 to 96 hours, and we stop it when the syringe gets over. Now, if you ask me the evidence base for it, it is not very strong. And there are centers that have spoken to. Some people don't use it at all. We have been using it right from the inception. It is probably doesn't cause much harm, although we are not really sure whether it does much good. So which is why we tend to use it, but the evidence base is not very strong.
So any intraoperative renal protection in recipients?
Specifically, we don't do that. Mannitol is given during the anhepatic phase so as to keep the kidneys flushed. And if you see a drop in urine output, we think it could be because we try to mobilize this splanchnic circulation by starting terlipressin or vasopressin. By maintaining the fluid, the best thing that we do is we try to maintain the fluid balance, so there is less chance of hypovolemia. Other than that, it's the use of mannitol and starting terlipressin when we see that there's a fall. Of course, we use albumin liberally so as to maintain the intravascular volume.
A dose of tranexamic acid.
We use it at a loading dose of 10 mg per kg, but I think the recommendation is that you can use 20 mg per kg, but in our place, we use 10 mg per kg loading, and then it is continued as an infusion at 1 to 2 mg per kg per hour. The recommendation for the doses are much higher, but this is a dose that we use and it works for us.
And empirical antibiotics or antifungal antivirals in the intraop and immunosuppression in the immediate post-op period.
Okay. So as a shall I answer that?
Yeah.
So as a routine, the go-to antibiotic that we tend to use is piperacillin tazobactam. For an average adult, it will be a 4.5 grams IV TAD and fluconazole. So that is what we tend to use routinely. Now, that will be modified based on the preoperative cultures or if they're at higher risk. So if they're at a higher risk, we tend to change that to carbapenem, usually meropenem or doripenem. We continue fluconazole intraoperative and post-operatively, and unless there is evidence of carbapenem resistant bacteria, we tend to use them. Occasionally, we have changed to use tigecycline as well in the immediate post-operative period, and again, that is based on preoperative cultures, and if you're really concerned about that. Routine antifungal is fluconazole prophylaxis. We don't go for empirical echinocandins, i.e. anidilafungin or caspofungin, unless that is backed by a positive culture from a colonizer site. I hope that answers the question.
Thank you, Dr. Subair. And another query is regarding the post-op fluid management in patients with massive ascites.
So as was alluded to, that is a tricky aspect. So we have to keep a very close eye on the hourly intake and output and the daily intake and output. Now, along with the urine output, there's a huge amount of ascites that gets drained in most of these patients. It could be maybe 2 liters and sometimes up to 3 liters of ascites that gets drained in these patients in the first few days. That's usually a reflection of the portal hypertension preoperatively. Now, if the ascites volume doesn't come down in the first few days, that is something that you need to be worried about, because it could be that they have got a portal thrombosis that is contributing to the for the portal pressures not to drop even though the liver is functioning reasonably well. So how do you deal with that? So a combination of crystalloids and colloids is what we tend to use. So the colloid replacement is what we tend to use. The colloids are what we tend to use to replace the ascitic loss. Now, for every liter of ascites, as a ballpark figure, for every liter of ascites lost, 20% of albumin, 100 ml, is given to the patient. And in order to mobilize the ascites, usually we tend to give furosemide along with that, could be 10 or 20 milligrams. And after the first 2 to 3 days, if the potassium, we find that the potassium is not going up secondary to the use of, as alluded to, calcineurin inhibitors, we tend to add aldactin as well. That tend to mobilize the ascites, and you tend to take the fluid away from via urine. Crystalloids, maintenance crystalloids are given if they are required, and usually after day 2, it is usually on an SOS basis, because we tend to provide them feed as much as possible right from day 2 onwards. So plasmolite is what we tend to use normally, which doesn't have lactate. It's a balanced crystalloid solution. unless they have got renal impairment or acidosis, in which we may tend to use half nasal swallow echo. Hope that answers the question.
Yes, well. Any more questions from the audience? Or any more comments from the senior faculties? Please unmute.
Lakshmi there?
Madam, just now left.
Okay.
Madam, കാണാനില്ല.
So participants can unmute and they can ask questions directly if they want.
Anyway, it's an excellent presentation by the team Amrita, no doubt about it. They are the pioneers in liver transplant program in Kerala. And probably they have the largest number of series in South India. We can proud of it.
It's Rajesh.
Shamshad madam, any comments?
Yeah, it was very good. And